ये जो है ना, इसको आप अपने डेस्कटॉप पे ले लीजिए। तो मैं पेन ड्राइव हटा अच्छा आपका ये वॉलपेपर है। अब मैं सिंपल चला लेना उसको। ठीक है तो जो इसका यूज अच्छा वो भी
वो तो
तो मुझे एक फ़ोटो अटैच करनी है तो मैं वो ट्रांसफर तो ये जो आपका व्हाट्सएप खुलता है कैसे? व्हाट्सएप वेब खोल लेते हैं। हाँ तेरे चल रहा है तेरे इसमें नेट तेरे से नेट चल रहा है। आपका ठीक है।
अब इसमें कोई इम्पोर्टेंट
May I request all the participants kindly take your seats so that we can start with the session? By then, I request Mr. Yash to showcase his talent so that he can keep us occupied. Thank you, Yash. That was wonderful. Good morning to everyone present here today. I am Ruhi Ahmed. I, on behalf of TYAcan Foundation, extend a warm welcome to everyone at the 11th National Conference on Teenage and Young Adult Cancer, Indore, MP. We at the Foundation are proud that we have organized an annual conference of all the health professional interested in the journey of young people with cancer. An annual event uniquely brings treating doctors and nurses with survivors and caregivers, where the science of cancer medicine for the young meets the spirit of social entrepreneurship. During the course of the next 2 days, we will deliberate on how we take care of young people with cancer and how we hold their hands in their journey as a cured person. It is a big day for everyone who has been a part of TYAcan Foundation in the present or the past. For the past 11 years, our foundation has made many accomplishments and has impacted thousands of lives and for their good and better. It is a special day as it celebrates the success of our mission, which is every young person must get a chance to cure and live the life of his dream to the fullest. This annual meeting is the first in person on one in the 3 years and the first one in Indore since 2016, and the first one with a complement of an oration, a debate, and a quiz. Life is about making the right decisions and moving on. Let me take the pleasure to call the ringmaster of the organizing committee of TYAcan Team 2020, Dr. Colonel Prakash Chittarkar, who has been guiding and supporting all his lions and lionesses to ensure that this 11th National Conference on Teenage and Young Adults Cancer must be conducted flawlessly. So here is Mr. Dr. Colonel Prakash Chittarkar.
Thank you, Rui. Very warm welcome to each one of us, you present and some on the way, and many delegates who have actually logged on to the live streamed version of this conference. Now, I think this is what we learned from the pandemic. Can you remember a couple of years back, we used to either go for a conference or not go for the conference. Now you don't need to go for the conference and you're there. So the pandemic has taught us all this. The next thing the pandemic is going to teach us teleportation, but that's a little later. But so great to see all of you here after 3 years since we last met in Jaipur under the stewardship of Dr. Malhotra in MGM Medical College in 2019, and first time in Indore since 2016. I extend a very warm welcome to each one of you, the several hundred young people with cancer, young persons with cancer whom we ever got to touch, and we learned we saw the spirit of divinity in them. And as I always say, it's heaven to be young, and the dawn of life actually starts at that age. That roughly the age in which we doctors try to treat those difficult diseases like cancer. It's by the way, this is what one needs to do is to put your healthcare in the context of social life, and that's why the word social entrepreneurship. Thanks. Where do I find? Yeah. Yeah. Pen drive. Team TYAcan. ये कर- ये- इसमें टीम TYAcan. नहीं. कहाँ गया? Where is it? Pen drive? नहीं, like it. नहीं, उधर ही. हाँ. Yeah, sorry, some glitch. Uh, welcome, Dr. Poorna Kurkure. Give her a big round of applause. She's the past president of the TYAcan Foundation, but that's a very small way of introducing her. She's a professor emeritus of pediatric oncology, and she's currently the medical director SRCG Children's Hospital in Haji Ali, Mumbai. Also the head of the Cancer Collegium of the Narayana Health a group of hospitals across India. Uh, there we go. So we'll, without taking too much time, we'll quickly run through the journey since 2012. Uh, Firstly, welcome to all of you. And most importantly, this year we've chosen Northeastern India as the region in which we like to learn from their experiences, how they have handled young people's cancer. And you know, there's a huge effort from the government and from several agencies across India to improve the situation. There are some unique numbers and unique epidemiology in Northeastern India. And there's a huge effort also towards it. So we want to learn from the colleagues from Northeastern India. At least one of them has been able to come here, Dr. Vikas Jagtap, and the remaining will be they'll be there online, and that session will be tomorrow. But that's actually the central theme of this year's TYAcan conference. This year we have instituted an oration in the memory of late Dr. G.S. Bhattacharya, the professor, luminary, friend, and mentor to so many of us in TYAcan. We lost him in mid 2021, COVID, very, very unfortunately. And none other than Dr. Poorna Kurkure, the past president, will deliver the oration. TYAcan, to all of you know about it, but it's a national non-profit dedicated to teenage and young adult cancer. Its debut was in Faridabad, of all the places, in April 2012, when we first thought of getting together the healthcare professionals interested in young persons' cancer. And this is myself in the auditorium of Asian Institute of Medicine in Faridabad in April 2012. Then we just quickly come to the perspective of this. Basically, in our large populous country, more than half of our population is below the age of 30, and 6 to 8% of our cancer burden actually consists of young people's cancer. And therefore, we expect every year about 80,000 new young persons to get diagnosed with cancer. They are always in the prime of life, full of hope and aspiration. They may have some early dietary deficiency, especially in the hinterland of India. We're not talking about metros and so on. So, but they're sensitive to most therapies, and their cancers are actually curable if and they can. Most of them can tolerate all the intensive cancer treatments, quite similar to the pediatric protocols, and they're likely to achieve a long-term disease-free survival. But they always fall through the cracks for the reason that they're neither adults nor children. They're not children where the focus is a lot on them because of the family and the society, and they're not adults so that they don't have the means to actually get their own cancer treated. The age definition, well, we fell back on what the Government of India, Ministry of Youth Affairs had to say in the website published in 2015-16, where in the National Youth Policy, they clearly define youth as persons in the age group of 15 to 29 for all programs, benefits, and for all endeavors. In other countries, there are different age brackets, but we in the Indian Academy of Pediatrics and TYAcan and Indian Society of Medical Oncology, everywhere we actually brainstormed and came to the conclusion that in India the time limit, the age bracket should be 15 to 29. And just briefly to run through what is a young person, what are his unique concerns? Autonomy. He's just going away from childhood, getting into adolescence and young adulthood. Independence, control, education, employment, companionship, life partnership, sexuality, privacy, body image, fertility, marriage, children, and so on. Finitude, end of life. I imagine this last thing comes up all of a sudden only because of the cancer. And so life is a dream run until cancer wakes you up, so to say. However, the tagline of our foundation is cancer survived with a life revived. The mission being to ensure every young person with cancer gets an opportunity for cure and to live life's dream. So we address a composite population consists of survivors of childhood cancer and young persons with cancer between this 15 to 30 years of age. So this is a very unique population of individuals, but this has to be bifurcated into two, because a 6-year-old child today who gets cured of cancer, another decade down the line, he's going to become a AYA or a TYA, adolescent or and young adult or a TYA, and his concerns will be same as the AYA who gets cancer today. How do we get there? Access, awareness, age-appropriate care, and advocacy. We'll talk about it in the next 1.5 days. And the vision is somewhere to reach every young person with cancer by 2027. I don't want to extend this deadline every year. I did for that. We have to work together and make sure that we reach every young person with cancer diagnosed in that year, in the same year, in the year 20, at least by 2027. The world history of TYA cancer movements run something like this. We all knew they all fall through the cracks, so to say. To use the term by Susan Sontag, who was herself a cancer survivor and later on became a New York Times journalist. Survival increments among them lagged behind in 99, while pediatric and even young adult medicine showed improvements. And in Harley Street, London, which is a doctor's street, the musicians and showbiz persons promoted the cause of young persons with cancer sometime in 1990. And today they started that movement of social entrepreneurship, of making the society aware of cancer in young people. And today there are 28 dedicated centers for young persons with cancer in the British Isles. And British Isles is smaller than, just a little bigger than Telangana in area, and less than population in the state of Madhya Pradesh. State of Madhya Pradesh, 84 million people, and the British Isles have got 64 million people. So you can imagine there are fewer people. Only 7 new young people get cancer in the United Kingdom every single day. And in India, 240 new young persons get cancer every single day. So you can imagine the dimensions of our challenge. So this cartoon is very, this little orange in between that you're seeing actually pertains to young people, where you can see it's extremely narrow and it actually crosses. So the survival benefit of young people with cancer actually is sometimes in the negative. It means they may be doing worse than so many other groups. And that was so in 99, but it's all that is changing. In Europe today, 85% of young people with cancer survive their cancer and become normal adult human beings. And in pediatrics, it's gone about 90%. And in India, we don't know, but it is obviously very a long way to go. The awakening worldwide, sometime in 90, we talked about UK, in the United States, when they first published the progress review group report in 2007 with the NCI and Livestrong Foundation by Lance Armstrong. That is the time the young people's cancer came to the fore in the United States. And in India, we actually registered the foundation, Teenage and Young Adult Cancer Foundation, 2016. But we started sensitizing meetings every year from 2012. This is a team, the consultants and the healthcare professionals, over 100 in about 21 cities. And the aim plus of survivorship is what the picture on the left, Sandeep and Ashok and everybody, you can imagine a healing survivor who lost his job in COVID in 2020 and started Digi Swasthya 2022. They need a big round of applause. Sandeep is here. right there. He's always there. And Sant, he started his venture in July 2020 in a little place called Sant Kabir Nagar in Uttar Pradesh. And then another small center in Bihar in Muzaffarpur. And today there are 5 centers, including 2 in Bombay, one in starting in Meerut. And they've already done 10,000 teleconsultations with over 200 doctors and diagnosed about 150 cancers. And among those cancers, in a short period of 2 years, 65% of those cancers are now treated and they're alive. You can imagine. So this is the beginning of social entrepreneurship by a survivor of cancer. This is what we want. This is what scores of survivors of cancer can do. So from academic interest to social entrepreneurship, maybe we are in the 11th year of our endeavor in the since 2012. We can talk about it now because you can't keep on discussing disease entities. That's been discussed ad nauseum by doctors, nurses, and everybody, all by conferences every weekend on the Zoom, in the webinars, and so on. So almost 4 times a week you have webinars and whatnot. But to carve out a niche for young persons with cancer in the cancer landscape, we need identification of disease nosology in our country, care pathways, curriculum, some curriculum, and scaling up the volunteerism and address the 4 A's that we talked about: access, awareness, age appropriate care, and advocacy. What is the vision for future? Well, you are there in this adventure sport like these 2 guys, and it's for you to young people to actually decide what the vision of the future is. In the Northeast, a special welcome to them. We created a session devoted to the challenges and welcome the 7 sisters, learning from the experience of integrating the best practices across India in that unique region, applying the solutions in other regions in a culture appropriate manner. So India is a unique laboratory where we are not a homogeneous culture. There's so many, and we are trying to focus on something very, very unique. One little age group and those cancer entities, but we got to be culture specific. We got 1,400 dialects. We got 28 languages. We got 29 states. We got so many things. But we got to do all this perfectly well. And who better than us to do with all our culture and our history? So arrival celebration as of yesterday. So we get cracking with this conference. Thank you so much. Over to you.
If you light a lamp for someone else, it will also brighten your life. With the name of the Almighty, let us begin our day with the lighting of lamp ceremony. It's been our tradition that we light the lamp by the hands of our brave cancer warrior. Keeping the same spirit, I would like to invite Miss Nabdita and Miss Oindrilla, who have come all the way from Kolkata to attend this conference. Please welcome them. Along with our dignitaries, Dr. Colonel Prakash Chittalkar, Mrs. Anjali Chittalkar, kindly come and do the honors. I also request Dr. Harbans Lal Kapoor and Dr. Malhotra and Dr. Puna Kurkure. या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभ
वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभ
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
A humble request from all of you, kindly put your mobile on silent mode. आप सबसे निवेदन है कि आप अपने मोबाइल साइलेंट मोड पे या वाइब्रेशन मोड पे डाल दें। थैंक यू। Moving on to next. Coming to the first academic session, which is going to be a quiz competition compiled by Dr. Runo Sharma, consultant medical oncologist, Max Super Specialty Hospital, Dehradun, and an alumnus of this institution and a passionate doctor for young person with cancer. This quiz will be conducted by Dr. Aditya Alhens, who recently completed senior residency in medical oncology, Sri Aurobindo Medical College. We also have participants from across the country, from postgraduate institutes doing DM and DNB courses. May I now request Dr. Aditya to come on the stage and conduct the quiz.
So good morning, every one of you. I'm Dr. Aditya Lens. On behalf of TYAcan, I welcome you all this morning. And I will be here for the session number 2, that is the quiz. All the participants can take part in the quiz who are present here. You can log on into your mobile and laptop devices to www.TYAcanfoundation.org. That is without any spaces. And on the top of the page, you will find a quiz link on which you could click. Second of all, participants who are not here and are joining us through a Zoom link can also join by the same method through their mobile devices. The rules for the quiz are that all of the participants will have to answer 20 questions. And for answering these 20 questions, you will get a total time of 15 minutes. No, that The link is www.TYAcan foundation foundation.org. All of the participants who answer the right question will be awarded with 1 mark, and there will be no negative marking. The interesting thing about this quiz is that the first prize is worth Indian national rupees 15,000, and the second prize is worth rupees 10,000. So I hope everyone has logged in. The link gets active in 3, 2, 1 now.
Hello, link is active now. You can participate.
Wi-Fi, is there a Wi-Fi password? I would request the IT team to please help us here.
It is LASER 1234, all in small. LASER 1234.
I hope everyone was able to log on. You have to log on into www.tyacanfoundation.org. And on top of the page,
Sir, it's displayed on podium side screen. You can see there.
yes, you will be able to view the screen that you would see on your mobile devices. Has everyone been able to access the website? Okay, now we'll start with the. Yes, whenever you click. So this is the first question. You have to identify the cancer survivor. You can scroll down in your mobile devices. I'll be moving the slides forwards in an interval of approximately 30 seconds. One can answer in any order that they like. What is the most common type of cancer in children? What is the percentage of adult survivors of childhood cancer who go on to develop an adult neoplasm, which might be benign or malignant? Which of the following is an inhibitor of PDGFR? Sir, where? Sir, stand corrected. The question is right here displayed. Which of the following is an inhibitor of PDGFR? Probably there might be some glitch on part of the IT team that have not come on this. Moving to the next question. Which is not a paraneoplastic syndrome associated with lung cancer? The correct statement from the below. The seventh question is attachment of H. pylori to the gastric epithelium leads to activation of the NF-kappa B and increased which of the following molecules? For an adult survivor of childhood cancer, which organ system is the most at risk for disease during adulthood after exposure to treatment with potential toxicity? An actor was diagnosed with DASH in this film. You can see the poster for the movie. Pardon? Okay. So probably we can, if such is the case, we can skip this question. The risk of recurrence in GIST after surgery is high, more than equal to 5% in all except he hypothesized the angiogenesis theory for cancer, which states that a tumor is able to create its own blood supply. Dozens of cancer drugs were developed based on his research. His name is which of the following is a non-profit organization that provides information about the legal rights of cancer survivors? Which of the following side effect is less with S1 plus oxaliplatin when compared to Kpox? You have to identify the wrong match with respect to lenvatinib dose. In advanced TNBC, adding pembrolizumab to chemotherapy improved the survival if the combined positivity score is at least a dual score of 3 means. Which of the following? Which of the following statements about amivantamab is false? Surveillance of mental health disorder in adolescent and young adult cancer survivor, May 2022. Which of the following statements is correct? You have to identify the drug derived from this plant. You can see a photograph of a flower. You have to name the book written by this author. I hope everyone has marked the answers.
It's time. Should I close the quiz?
I request the IT team to give 30 seconds further and then probably close the quiz.
Okay.
So thank you everyone for attempting the quiz. I wish all best of luck to all the participants, and we hope to announce the result of this quiz in the valedictory session, that is the session number 12, which will be occurring in this conference. Thank you.
You are a warrior. Warriors don't give up and they don't back down. Pick up your sword and shield and fight back. Moving on to our next session, which is on hematological cancer in AYA. I invite Dr. Harbans Lal Kapoor, MBBS, DMRT, MD, eminent and senior most radiation oncologist, formerly Professor and Head Radiation Oncology, Indira Gandhi Medical College, Shimla, HP, as the chairperson of the session. May I have you, sir?
Good morning. I think I'm extremely happy to be here, and I feel highly enlightened. And I've come here to improve my vision and improve my knowledge. As I was speaking in the morning, that we learn so much from the students now, the younger generation. So much is happening in the field of oncology that jokingly, I was telling that before we start learning the spelling of a particular molecule and how to pronounce it, next we find that the molecule has disappeared. It is so fast changing scenario. If the paradigm shift has happened anywhere in the world, it is in the field of oncology. I would say that Three cheers to all the people sitting over here, led by Professor Chitalkar. I salute you, Professor Chitalkar, being the ex-army and everybody here. He has done an exceptionally great work, I would say. That's a trendsetter in this country. God bless you, Professor Chitalkar. And my association with him goes back to very, very early days in Simla when he was posted in Army Hospital across to my cancer hospital. That was just in the initial phases, and he would come and join me for the rounds. I really salute you and your efforts. God bless everybody sitting over here, all distinguished persons that I know of. I can't name individually. You're all great. I feel blessed to be here. So with this word, I would call the first speaker to come and talk about hematological leukemias, topic leukemias in TYAs. And the speaker is Dr. B.S. Ankit, Consultant Medical Oncologist, HCG Medical Center, Jaipur. Dr. Ankit, please. You are online, yeah. Dr. Ankit, you're there. You're not audible.
They're coming online, sir.
Hello, good morning, sir. Am I audible? Hello,
Yes, sir.
am I audible, sir?
Yes, sir.
So, Mr. Salam, sir, please allow me to start my video as well. Is my screen visible and am I audible?
Dr. Ankit, you're
Yes,
not
sir.
audible
Yes, sir.
still.
Yes.
We are running late in our program. You
Sir,
have
please start,
half an
sir.
hour.
Good morning to
For
all the esteemed
presentation.
faculties, delegates, and colleagues. And thank you, sir, for the kind introduction. And thank you, Chitalkar, sir, for letting me, giving me this opportunity to speak on leukemias in TYA. And my extreme apologies. I'm not being able to physically come there. So I'll start my talk. As already sir has mentioned about different AYAs and TYAs in US, it is between 15 to 40 years, and in UK it is 15 to 25 years, and Canada it is between 15 to 30 years. So in India, after in 2015, but they decided that the TYA, according to the Indian Ministry of Youth and Sports Affairs, that the teenager and young adults should be defined as between 15 years to 30 years of age. So, so the prevalence of leukemias and TYAs, as we see, the acute lymphoblastic leukemias and acute myeloid leukemias are almost the same, followed by 15% are CML, and rarely between 1 to 2% are CLL. And that is the prevalence according to the age group of 15 to 39 years of age. And if we see according to India, so CLL will be very rare, as we see in our clinical scenario. So so AYAs, adolescent and young adults, or we call it a TYAs, the cancer should be considered as a high risk group, because with the time, the pediatric patients and the older adult patients, the survival has improved with the new clinical trials and the new approved drugs. But in this clinical scenario, the AYAs, the survival is not improved that much because of the lack of the proper clinical trials and the recruitment. As we see in the ALL and AML, the younger individuals, like pediatric patients, have a superior prognosis than the AYAs. And in CML and CLL, the older individuals has a better prognosis than AYAs. So that may be because of the biology of the patients as well. But again, the AYAs have a unique sociological challenges as well, which is like delay in the diagnosis, insurance barriers, and the low rates of clinical trials, as I was talking about, and the lower adherence to the medications and the cancer and treatment plans, psychological concentration, and the financial issues. So this slide is again stating the cancer diagnosis and therapies are affected by multiple reasons, health related or the disease biology wise, or behavior, emotional component, social relationship component, the disrupted life goals. So the AYAs are having poor prognosis than the comparator arms. So if we see between the 15 to 29 years of age, the leukemias are the third most common malignancies, which depending on the incidences, which is around 9% of the all of the patients globally. And if we talk about the prevalence as well, it is like second most common malignancy all over the world, following thyroid carcinomas. And if we see the sheer death analysis, which is by the USA, so almost every year out of 1 lakh, 0.6 to 1.7 on an average, 1.6 patients are 1.6 patient diagnosed with ALL, 1.1 patients diagnosed with AML, and around 0.4 patients diagnosed with CML out of 1 lakh, which is quite rare, but it is a growing concern by now. And this is the Scottish data, which is again similar with the previous data, which is showing that AML and ALL, the incidences are around 1.7, almost around out of 1 lakh, and the CML is around 1.2 to 1.3, around 1 lakh. So coming to the specific types, so I would like to start with ALL because it is the most common type. So before going in the deep, I would start with the risk stratification. As we all know, the hypodiploidy and trisomy and translocation 1221 is the good prognostic markers, and hypodiploidy, so sorry for the typing mistake, and KMT2A, A21, and Philadelphia chromosome positive, and the upcoming PH-like ALL are the poor prognostic markers. So as we see, the PH-like ALL, which is the most concerned entity among the AYAs, which is AYAs and TYAs, which is most in the adolescent and young adults, and second PH positive patients, which is again poor prognostic, which is higher in younger adults. And the if we see in the bottom line that hyperdiploidy and ETV RUNX1 mutations, which are decreasing with the age. But if we see that yellow line, which is PH positive, it is going beyond young adults as well. So in the older adults also, it is the same. But specifically, if I would like to talk about the PH like ALL, which is the highest in the AYAs, and in this slide as well showing the same thing. So between the age of 16 to 40 years, the AYAs in 3 different trials and 3 different studies. The incidence is around 21 to 27% in first study, and then 25 to 18 in the second study, and around 20% in the third study, which is highest in all the patients. So definitely the biology of the ALL patient in the AY is different than the pediatric patient and the adult patients, and which is indicating around the poor prognostic markers. And so if the biology is different, then there was initially the patient was usually allowed to treat with the older adult treatment plans. And with that, we can see the LALA-1 trial, which is showing that 5-year survival is only 41%. And with the CalGB trial, the 7-year survival is only around 34%. And GMMA ALL trial is who won ALL trial is the 5-year survival is around 34%. But with the pediatric trials, which usually incorporates more of L-asparginase doses, more of DEXA doses, Nelarabine in case of T-cell ALL, and more of vincristine doses, we have seen that AYA patient and TYA patients are having a better outcome in comparison to the older regimens. So if we see this CCB trial, so 7-year survival is almost around 63%. And again, if we see the AIO trial and DCOG trial, Dutch COG trial, the 5-year survival is around 69%. So definitely with the pediatric therapies, pediatric protocols, the ALL survival is increasing. And this is the slide showing only the fully pediatric and pediatric inspired trials, which are showing almost around 5-year survival of more than 60% in all of the protocols. And so right now at this time, that AYAs or TYAs which is newly diagnosed with ALL should be treated with the pediatric ALL protocol and should be or incorporated in clinical trials. If MRD positive, then blinatumomab or inotuzumab with the bridge to transplant should be considered as a standard therapy. So if coming to AML, which is the second most common in TYAs, favorable, we all know this ELN classification 2017, 2022 classification has already come, and it's almost the same as the 2017 classification. So here also, if we see the favorable prognosis, only AYAs has a higher chances of PML RAR alpha. Other than that, all of the unfavorable type, like higher chances of 12p abnormalities, higher chances of inversion 3, higher chances of 6-9 translocation, higher chances of chromosome 5 abnormalities or monosomy 7 abnormalities, as well as the complex karyotyping is higher in AML patients as well. And here we can see this slide is showing that the blue ones are mutations which are more common in children's, and green ones are more common in adults, and red ones are more common in AYAs. So here we can see the CBPA is positive and more common in AML, but which is a good prognostic marker. But despite that, if we see the AYA survival gap, so if the patient who are diagnosed with the less than 5 years of age, the 5-year survival is almost around 70%. And if we see that the patient is diagnosed after the age of 25 years, the 5-year survival is less than 60%. And if it is beyond 35 years, the 5-year survival is almost around 50%. So here also there were many clinical trials. They adopted the pediatric trial, which was incorporating etoposide and mitoxantrone and gemtuzumab osagamycin in induction as followed by consolidation. So if we see the pediatric protocols, COG protocols, the overall survival is better than the CalGB and SWAP protocol, which were using adult or older adult protocols, and which is the OS is significant, EFS is significant as well. So this is coming to the third most common malignancy, which is CML. So there is CML in AYAs and TYAs is very rare. I found this study as a MD Anderson study. There was around almost around 470 patients. So in CML also, if we see that splenomegaly is more higher in AYA patient than the more adult patient. Sokal index is lower in surprisingly lower in AYAs. And but if we see that the median duration of therapy and median duration of response, which is higher in AYAs, if we can see this slide. So a clinical complete cytological remission, major molecular response, and complete molecular response is lower than whatever the patient who are more than 30 years of age. So which is 84% versus that 93%, 75% versus 86%, and 23% versus 41%. And a response to the therapy as well, it took a lot of time. Major molecular response at 18 months was 67%. Sorry, my apologies. So with newer therapies like second line therapies like nilotinib and dasatinib, we are aiming to have a higher disease-free treatment-free interval. So we are prescribing second-line TKIs in first setting, second generation TKI in first setting. So if you see the complete cytological response rate with the imatinib, which is 76%, with the nilotinib and dasatinib is more than 90%, and major molecular response at 1.5 year is 67%. Compared to 67 and 75% with nilotinib and dasatinib. And median time to response also complete molecular response, which came out to be around at 12 months with in the AYA group versus 24 months in the older adults as well. And if you see the event-free survival also, the AYAs so AYAs are having a poorer prognosis than the older adults in VC. And other than that, AYAs have specific issues like premature mortality in overall survival, cardiac or other comorbidities like obesities, cardiomyopathies due to the treatment side effects, endocrinopathies due to treatment, and due to treatment that there are more of infertility and sexual dysfunction as well, as well as osteopenia and osteoporosis. And other than that, socioeconomic issues like health behavior, healthcare need, emotional adjustment, social relationship, emotional, functional, and employment and finances are also up in the long-term survival of the AYAs are also very difficult. So to conclude my slides, so progress in the field of AYA, acute leukemias has been dramatic through identifying new genetic entities and adopting fully pediatric or pediatric inspired protocols. Risk stratification based on recent biological finding and sequential MRD evaluation should now be implemented as a new therapeutic options. The questions should be addressed with the specific clinical trials, because till date we have a very few clinical trials. COG has started few clinical trials, but they are like 1 or 2 only. So the highly involved and specialized team should be taking care of the AYAs. There are many challenges for their specific need, like reinforcing treatment protocols. Adherence is a major issue. Psychosocial support is a major issue. We should be addressing that. Ensuring proper fertility preservation, access to healthcare, insurance, education, employment, career path, and improving cancer survivorship care. So, one more I would like to add on that there should be in AYAs, there should be a strong collaboration between young adult oncologist, hemato-oncologist, and pediatric oncologist with the multidisciplinary team to improve their survival. So with this, I would rest my slide.
Thank you very much, Dr. Ankit, for having covered this extensive topic in the shortest possible time. Thank you very much, really. And please kindly stay on, because we'll have the Q&A session after the all the speakers have participated. So with this, I call upon Dr. Suneet Lokhwani, consultant medical oncologist from Jabalpur. Wow, Jabalpur is my alma mater. Oh, I feel so happy, and you're come personally. God bless you, Jabalpur. I'm from 64, sir. Welcome.
Thank you for the warm blessings. I thank the organizers for bringing me on this podium and the dais and giving me the opportunity to speak in front of an august crowd like this. I just ask for a permission. Sir, मैं हिंदी इंग्लिश दोनों में बोलना चाहता हूँ. Am I permitted to do so? So he is also a fantastic person otherwise as well, Sir Rahul Nathani, sir. So I'll begin with this. The topic allotted to me is Hodgkin's disease or Hodgkin's lymphoma, the paradigm illness in teenage and young adults. So I'll begin with this. So I called it as the coffee session because that's the time when we mostly drink the coffee in the starting part. Sorry, we are delayed by the coffee by half an hour or something. And I thank the organizers for giving me the chance to represent this topic. To start with, we should have a schema on which we will be learning about this topic. बहुत basic के बारे में बात करेंगे. I mean, we should know what it is. We should be able to tell people what it is, what should be done, and what is the scientific perspective of management. What are the newer drugs? So this will be in a tabulated and schematic form. We'll go one by one and let's see what comes along. I'll try to finish in the earliest possible time, sir, but please give me some time, sir, if I am delayed. चलिए आपके माइक से होने का फायदा है सर, थैंक यू. So we'll start with the basics. So one of my teachers used to say कि किसी बीमारी में इंटरेस्ट लेना है तो उसका इतिहास जानो. So learn about the history first, how it came into being. So 1832, आज से 190 साल पहले एक व्यक्ति ने जिसका नाम था थॉमस हॉचकिन, उसने एक पेपर बनाया जिसे कहा ऑन सम मॉर्बिड अपीयरेंसेस ऑफ एब्जॉर्बेंट ग्लैंड्स इन स्पेन. उसके बाद 1856 में Samuel described it, cases of enlargement of lymphatic glands and spleen. Subsequently, it was lost in the wild. Then in 1878, it came back again when Langhans and Greenfield, it described the microscopic characteristics in 1872 and 78. Subsequently, what we have is 1898 to 1902 description of the RS cell by Carl Steinberg and Dorothy Reed, in whose memory and name we name the cell the RS cell, the HRS cell, Hodgkins-Reed-Steinberg cell. My friends of pathology, if they are here, they'll definitely reminisce with this. It has got a basic of pathology also coming up. So that's where we describe Hodgkin's lymphoma first. So the fundas to be cleared in 2 lines. HD or HL is a type of malignant lymphoma in which RS cells are present, characteristic background of reactive inflammatory cells of various types accompanied by fibrosis of a variable degree. The beauty of this thing is RS cells का percentage आपके पास defined नहीं है. Even less than 1% of RS cells is sufficient enough to diagnose Hodgkin's disease. And I'll tell you why we should appreciate our pathologist friends and histopathologist friends in the next slide. So the clonal cells usually constitute less than 1%. So this is what a RS cell looks like under a microscope and H&E staining. उस जमाने में इसको owl's eye बोलते थे. आज मुझसे पूछेंगे तो मुझे शायद minion की आंखें लगेंगी. So people can appreciate who know minions. So this is known as an owl eye appearance classically. High magnification of lymph node section, a patient with Hodgkin lymphoma, RS cell, center of the field with classical findings of giant size compared to background lymphocytes, binucleation and prominent eosinophilic nuclei. What they are per se, they are just crippled germinal center cells. Crippled matlab langde, ek tarah se bataya jaye. They are faulty in their development and division per se. They don't have normal B surface antigens. The manipulation of single RS followed by PCR clonally rearranged but non-functional immunoglobulin genes shows somatic mutation results in the stop codon. Henceforth, the rapid multiplication, and there is no apoptotic death, leads to malignant transformation. How this occurs, still unclear. 50% of the cases of Hodgkin's are affected by, do have an etiology of Epstein-Barr virus, but rest 50% is idiopathic still. This is the reason why we should appreciate our pathologist friends. In this much of that, they have to appreciate one cell. They have to find needle in the haystack. So even one cell is sufficient enough to give the diagnosis. Less than 1% of cell population. इतने सारे cells में से एक RS cell ढूंढना, it's a tough job. So that's why the pathologist has a good job to do here. So I appreciate my friends here when they diagnose somebody with Hodgkin's with surety. To divide, it has 2 types, classical and NLPHL. Classical has 4 variants. The nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted. To describe, the nodular sclerosis variant is the most common one, 80% of the HL in older children and adolescents, but 55% of Hodgkin's lymphoma in the adult population. कैसा दिखता है? Dense collagenous bands divide the lymph node into nodules, and Hodgkin's RS cells may be a variant known as a lacunous cell. Mixed cellularity, 20% of children younger than 10 years and 10% of children and adolescents. Often prominent eosinophils are seen. Again, lymphocyte depleted and lymphocyte rich are rare. No need. The idea what we need to know here is we have to separate the lymphocyte rich from the NLPHL variant. That's why we need to know about the lymphocyte rich part here. So the NLPHL, only 5 to 10% of HL cases. I somehow believe, or what we read is NLPHL is specifically a separate category. It doesn't behave classically as Hodgkin's per se. And what we need to see here is they are lymphocyte predominant cells. The nuclei are more or less popcorn-like. They burst like a popcorn. That way we call them popcorn cells as well. Earlier they used to be called LNH cells भी बोलते थे इन्हें, lymphocytic histocytic variant भी कहा जाता था. And they have distinctive characteristics that distinguish them from RS cells per se. So again, germinal center से ही निकलते हैं, but the bulk of tumor mass in LPHL consists of abundant reactive non-malignant cells, not malignant part of it. They surround the LP cells here. They are morphologically distinct. They are not associated production of pro-inflammatory cytokines, utilize different mechanisms to sustain growth and survival, and are surrounded by different mixture of reactive cells. No. So this was the pathology part. Patient हमारे पास क्या कह के आएगा? What the patient comes to us with? Common presenting symptoms of Hodgkin's are lymphadenopathy, systemic complaints, and sometimes a mediastinal mass. Results of the cooperative group studies show that 80 to 85% of patients with HL present with only lymph nodes and or splenic involvement in stage 1 to 3. The systemic complaints, when we tell that, mostly they are fatigue, anorexia, and weight loss. The B symptoms, which we all know, B symptoms, fever more than 100, drenching night sweats, weight loss of more than 10% in 6 months. So B symptoms definitely portend some more unfavorable prognosis rather than a favorable prognosis. That's why we need to know the B symptom part. So in one line, if you ask me, the best way to find HL early is to get on the lookout for possible symptoms. The foremost common symptom is an enlargement or swelling of one of the nodes, causing a lump or a bump under the skin, which is painless, which usually doesn't hurt. So that is one thing we should always look for. So this interesting trivia I have kept for medical oncology PGs, if they are here. I don't know, sir, if they are here. There are some. I mean, can somebody please raise their hand if they're doing medical oncology postgrad here? They are not here, I believe. They are here. So it's just an interesting trivia. So can you make out what I'm trying to show here? बता सकते हैं मैं क्या दिखाना चाह रहा हूँ? Anybody can take the call, please. Yes, alcohol वो तो दिख रहा है, पर मैं बताना क्या चाह रहा हूँ? Alcoholic habit. Sir? No, sir. कहते हैं शराब सारे दुखों और दर्द की दवा है. इन केसेस में अक्सर शराब पीने के बाद दर्द होता है. So what? Yes. In rarely patients of classical Hodgkin's, there is a complaint of severe pain following alcohol ingestion. अक्सर when there is marrow affection, तो उसमें हड्डियों में दर्द होता है दारू पीने के बाद या शराब पीने के बाद या मदरा पान के बाद, या फिर नोड्स जो हैं जो ऑलरेडी बड़े हैं, immediately after small amount of alcohol, they'll severely pain. So one of the classic diagnostic clues towards Hodgkin's is this. So that's what I wanted to portray. So how do we go about working this disease up? First and foremost, to all the PGs sitting here, to all the doctors sitting here, history and physical examination hold the clue to your diagnosis. Presence, duration, and extent of lymphadenopathy. Three things are most important. Take them in depth, and we will be definitely coming to a somewhat conclusive statement if we are taking these three in proper line and array and chronology. Any other symptoms? Fever, sweating, weight loss, pruritus, alcohol-induced pain. Many of the, then other than that, we do routine blood tests, that is CBC, LDH per se, differential counts, and liver and renal function tests along with ESR. What they do basically is they are used to determine the presence or absence of organ involvements as well as propensity of the patient to relapse following conventional treatment. So in a resource limited setting like ours, we should definitely have these, and it definitely gives a marker or a pointer, like an elevated LDH definitely portends to a poor IPI part in the foreground when we calculate the IPI. So that's why that's where they help us. So that's what we need these blood investigations for. Next is nab the node, get a tissue biopsy. Remember one line when it comes to lymphoma: excise the node as a whole, give it to a histopathologist. That's it. There is no role of FNAC in this. No arguing, no discussion for that. There's no room for that. So you have to cut the node in whole. The histopathologist will gross it, microscope it. They'll appreciate the architecture, the loss of architecture, and everything which resides there in the node. And then they are able to say in a short pattern that, yes, sir, we are dealing with Hodgkin's or we are dealing with the non-Hodgkin's. And it's a lymphoma oblique, not a lymphoma, something else. So excise the node in a whole and send it across. This is one place where I would beg to differ based on data itself, that tissue biopsy or core biopsy is not a sufficient parameter. At places where the nodes are not accessible, tissue biopsy or core biopsy is permitted, but multiple punctures should be taken. like the axial skeleton part, not the peripheral part where you have lymphadenopathies. So that way, in a practical manner, definitely. But other than that, you should definitely excise the node. So this is for our PGs actually. So this is the IHC classification. Please have a look at it. You'll deal with it day in, day out the moment you come out into practice. What you need to see here is the difference between the classical and the NLPHL part. Classical is CD1530 positive, NLPHL is CD1530 negative. So one of the drugs which I'll be telling later on, brentuximab, will not be effective in NLPHL. That's what you need to know. Somebody might ask you in a viva as well. So these are some things you should keep a pointer for. Other than that, EBV is seen in classics, not in LLPHL part. Next thing, somatic happy mutations are not seen in classic variants and are most commonly seen in NLPHL part. Coming to the imaging. Imaging is PET-CT, and PET-CT, nothing else. Nothing else suffices. So PET-CT, and PET-CT, nothing else. Imaging, anybody asks Hodgkin lymphoma, sir, PET-CT, you will nowhere be wrong. And every modern guideline or management of lymphoma coming up nowadays is based on 18-fluorodeoxyglucose PET. So PET-CT is the thing. Why? I'll tell you. The next imaging will tell you. See, if you can appreciate this. That's your classic. See, to the anatomic detail. This is the PET which checks the tumor viability. You combine both. Superimpose the PET on the CT. You are able to appreciate where your nodes are. What are the issues? You can appreciate whether they are brighter than the liver or brighter than the mediastinum or less brighter than that. So that's the idea. So coming up with this is highly sensitive and highly specific. When you get a CT, there is less number of false positives. When you get a PET, there is less number of false negatives. So the idea is to have the highly sensitive and specific information. So that PET-CT will definitely give you and guide you. So this is what we call as the D5PS. You will score. I think a question was also asked in the quiz, if I'm not wrong, on this. So if you've done wrong or right, you can just correct it right now in your mind. You cannot correct it, go back and correct it in the quiz now. So it's basically what you call is negative is D value 1, 2, 3. The 1 is no uptake. The 2 is less than mediastinum. 3 is more than mediastinum, but less than liver. Then the 4, 5 part is the positive part. The uptake is moderately higher than the liver and visually above the adjacent background activity. This 5 part is markedly much higher. That's what we call the 5. And something arising as a new lesion per se is known as X, which is not related. So this is a pictorial representation of 1, 2, 3, 4, 5. So it's observer based and it is very specific that way. So why PET-CT is important? CT is not showing anything. PET is showing something. When you combine those, you see that the patient has focal lesions in the bone marrow which are not visible in a CT. In the modern guideline, when you work up a case of Hodgkin's lymphoma, bone marrow is not needed because PET-CT is there. A focal uptake in PET-CT signifies bone marrow involvement. A diffuse uptake of the marrow is rudimentary or not important. So it helps us in avoiding one of the invasive investigations, that is bone marrow aspiration oblique biopsy. So that's where PET-CT also helps, other than the staging part. So why I have kept this slide is what we should realize. The red blocks are the PET-CT at starting, at interim, and end of therapy if you want to. Very simple. They have come up as a big time marker in guiding therapy in these 3 areas. You get it done in the start, give 2 cycles, again assess and give it at the end of therapy. So the idea here is basically you need to know what the disease response is per se. After end of therapy, there is no use in Hodgkin's. With the immunotherapy coming up, yes, definitely PET-CT has a role in the modern immunotherapy status. So we can again check whether immunotherapy is responding to it or not. So this is for my medical oncology PGs and the doctors of our fraternity. There are new parameters which are coming up. This is something we should all know. Probably 1 year down the line, these will be used most commonly in the PET-CT. The first is total metabolic tumor volume when we assess the PET-CT and the tumor distance. क्यों जरूरी है? तो इससे हम ये पता कर सकते हैं whether there is a high propensity of the disease coming back or not. बीमारी वापस आने की propensity हमारी कितनी है? So this is metabolic tumor volume expressed in a bar graph, the threshold versus the max, and this is the partial volume effect which is left off. So this is calculated by a logarithmic function. So this is how you calculate the MTV computing. It is done this way. All the FDG tumor masses automatically contoured on a dedicated software. The areas of physiological uptake are manually removed. There is an algorithm which computes tumor volume, starting photon counting by the so-called process of tumor segmentation. Then only voxels with a SUV between the SUV max and a given SUV threshold are computed to correct the partial volume effect. The threshold could be a fixed percentage of SUV. SUV is the standard uptake value, or an absolute value of SUV more than 2.4, 2.5, because we consider SUV 2.5 more than clinical importance. The counted voxels are transformed into volume unit, that is centimeter cube. The sum of all the computed voxels allow the calculation of MTV. And then there is another parameter, tumor lesion glycolysis. The higher active the tumor, the more metabolically active it is. So it also helps. So these are the two new markers coming up. All my PGs here or RPGs here and the doctors concerned can definitely note it down. So this is a paper which assessed, they studied 59 patients of HL treated with ABVD plus minus other treatments, and total mean tumor volume was assessed with SUV max thresholds of 47%, 41%. What you need to know is the ones with the lower one had a good survival, the ones with the higher one had a lesser survival. That's what we need to know. The next best thing which is coming up, and it is very easily calculatable, that is the Dmax, the distance between 2 points which are positive on a PET CT. Dmax is defined as the longest distance in centimeters measured between pixels belonging to any couple of sites determined detected upon tumor segmentation among all paired lymphoma lesions. So this is the study, Dmax in HD0607 trial. What they found out was, only the red line you need to know, with a cutoff value of 16.2 centimeter turned out to be significant in predicting relapse. So the higher the Dmax, the more is a chance or propensity to predict the relapse. Now, the big part of the disease, the management part, I'll just briefly conclude it so that we know all. So when we start the management of the disease, there are risk protocols as well as staging involved. A simple margination has been made between early and advanced disease subsets with sub-classification by adding favorable and unfavorable assets to it. Aapne stage kiya, unfavorable parameters or favorable parameters saath mein laga diye. So that's how you distinguish it. This is the staging part. Stage 1 is only one group of lymph nodes, paired group of lymph nodes above the diaphragm, below the diaphragm is 2. Then both the sides of diaphragm is 3. Then paired lymph nodes at both the sides of diaphragm is 4, and marrow involvement includes 4. So these are the sites or lymph node regions in lymphomas which are involved. The peripheral ones are more accessible, and wherein we do the excisions and the biopsy assessments, and central and axial ones, I referred that we should definitely go for a multiple core biopsies. समझ गए सर, ज्यादा टाइम नहीं है मेरे पास. So this is how you classify. सिर्फ दो चीजें आपको देखनी है. Bulky megakaryocyte disease more than 10 centimeters, or the ESR is high, fits into the unfavorable or the favorable parameter. So that's how you manage. देना क्या है? What to give? ABVD, 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 ABVD. I am not wrong in telling this. Escalated BCOP in special situations. Idea is to limit toxicity with continuum of care being given and continued. Idea is itna sa. So if you see ABVD into 6 versus BCOP into 6 escalated, ABVD has got a higher cure rates and morbidities. Isme escalated BCOP mein zyada. So intensity or extent of therapy is defined by this algorithm. So hamesha ladai in dono mein rehti. But modern protocol, ABVD is the norm. Upfront you have to give. So the strategies, again, I told, it is basically to de-escalate the therapy and limit toxicities. That's the idea here. That's why we are giving ABVD. And if you're starting with BCOP, escalate or de-escalate based on the interim PETs. The interim PET idea yahi hai ki aapko toxicity limit karni or cure provide karni. That's the idea. In summary, interim PET allows safe de-escalation. We have multiple trials, including the RATHL, the HD18 and the AHL1. The RATHL one was phenomenal, where after interim, there is a good response of level 1 to 3, you omit the bleomycin. Simple. That's what we've mentioned here. This is why I'm saying ABVD, ABVD, ABVD everywhere. Stage 3, 4, stage 1 to 3 unfavorable, stage 1 to 2A favorable. Everywhere it is ABVD 2 cycles. Blindly give ABVD. 4 drug combination, 2 cycles you have to give. Then after this, there is evolving in the world. There is evolution going on. We have new drugs. We have immunotherapy coming up. Brentuximab is a new game changer. Brentuximab vedotin is an antibody drug conjugate with CD30 directed antibody linked to antitubulin agent monomethyl auristatin E. And which subset of Hodgkin's is it applicable to? PGs, please. Classically. Fantastic answer. You are attentive. Thank you. So there's been an article. Is it the time to change the B in the ABVD from bleomycin? Should we change it to brentuximab? This is the high time that ways. But problem is this, that we have the guideline for that. The guideline clearly mentions, yes, you can use it. It's got a good result and it has got a superior result than ABVD. But problem with brentuximab is this, the financial toxicity part. When we were doing our PGs, if somebody in their wildest dreams had a very good TPA and a very good insurance he had, and he came to us, sir, I have insurance of 50-60 lakhs rupees. What is the drug you can give me? I have Hodgkin's relapse. So we used to give him brentuximab, और आप लोग जो selfie लेते हैं ना, हम उस दवाई के साथ लेते थे. Because it's such a costly drug, once in your lifetime you give it. One dose costs 9 to 10 lakh at that point of time. And you have to keep giving it. So the idea is the financial toxicity is the limiting factor. Other than that, this study shows that there is an excellent response to brentuximab compared to classic ABD. You should give it. हो सकता है in the future, times to come, we'll definitely have a biosimilar or a cheaper version of it or a generic version of it. But definitely brentuximab is a drug to come in the next generation. Subsequently, there are other drugs also. There are other treatment approaches. I'll just finish with this. Subsequent approaches for relapsed refractory disease, the drugs which are taking the world by a storm now. I put it to my PGs. Can anybody guess which drugs I'm talking about? The hint is the immune system game players. Yes, the PD-1. The PD-1 people, the Pembro and the Nivos. So, harnessing the immune system in management of classic Hodgkin's, incorporating novel agents. The idea is nivolumab and pembrolizumab approved for relapsed disease at present. They have not been approved for upfront. There are ongoing studies for upfront use, and they are showing good results in this. So these are the studies which I'm mentioning. I'm just skipping the studies per se. I am limited with time. These were beautiful studies which showed Pembro and nivolumab action. And the idea here is balancing risk with benefit for the individual, highest curative primary therapy and optimal survivorship. Take home message, HD is a curable entity. Don't miss PET CT. Don't ignore the swellings in your young child or the youth. These are the three take homes which I would suggest here. And thank you for patiently listening.
Thank you very much, Dr. Smith, for an excellent talk, and you have covered the entire spectrum of the diseases. And of course, I'm very happy that you struck a note of caution regarding finances. I do mention at times that it is more costly to take care of the side effects and the toxicity than the main treatment. So we have to strike a balance. It's very, very important. I'm very happy to mention about that. And of course, as the scenario is changing so very, very fast, we have newer molecules coming. We forget the names. The only two names I remember is MAB and NIB. मैंने कहा मैब एंड निब है, उसके बाद आप वो जो स्पेशली सुपर स्पेशली वो बताएंगे आपको क्या है इसके बारे में. But nib also you should have the right nib, because the King of England used that pen, that nib started leaking. So you must make sure that whatever nib or mab you have, they don't start leaking and cause the toxicity. Then that is going to be more costly. So I'm so happy that you mentioned all these facts and all. You brought the entire gamut of the disease pattern and the treatment in a very, very lucid way. Thank you very much. And thank you very much, Jabalpur Medical College. Wah, wah, wah. I'm being a little partial. You will excuse me for that. I became sentimental, yeah. I'm from ages 60s and all. Now, with these words, I'm very happy to call upon the final speaker, the last speaker. Last but not the least, the Dr. Vinay Bohara, the consultant hematologist, CHL Hospital, Indore, the local, yeah. Dr. Bohara, please.
Good morning, everyone. Thank you, organizers, for this opportunity, and thank you for calling me here. I've been asked to speak on bone marrow transplants in AYA, but as I speak on transplants, I'm a little bit anxious because I find myself very small in front of Chitalkar sir's aura as I speak into transplants, because whatever I know of transplant, I think 80% of it I've learned it from Chitalkar sir. I remember 2016 when I had moved to Indore, and that time I think we were not doing many transplants in Indore, and like a father figure, Chitalkar sir actually was there with me in every step. So we were separated, by 15 kilometers. I was in CHL in the city, sir was here. So I remember in 2016 when I did my first transplant, sir was there with me, and of course time has passed, but sir is still there to guide me as a father figure. So if we peep into history, first bone marrow transplant in India was done in 1983, the year I was born. So I'm turning 39 today. And so over 39 years, starting from first transplant, we've seen exponential rise in the number of centers which are actually doing transplants. But still, transplants of AYAs, adolescents, and young adults, it holds a special place because we all know that AYAs are not small adults. If we define them, different continents would define AYAs as, US would define them as 15 to 39 years, while UK, Europe would define them between 15 to 29 years. And I think we have adopted this 15 to 29 years. So why they are special? There are many things which are different in AYAs from adults, and that is what differentiates them. If we talk into epidemiology of certain diseases, for example, we don't find myelomas, myeloproliferative disorders in AYAs, while we find a lot of leukemias into this population. There are actually different, physical and psychosocial issues. When we offer them chemotherapies, when we offer them transplants, there has to be consideration of long-term effects like physical, vocational, psychosocial. And of course, right now also we have limited number of centers which actually cater to the needs of this particular population, and that's why they are different. So coming to transplant proper, there are different indications of transplants in AYAs. I think less than 50% of the patients who undergo transplant at this age would be for malignant disorders like ALL, AML, relapsed refractory ALL, AML, CML, not a very common indication, but those patients who fail on first, second, third line TKI would ultimately be offered allogenic transplant. And rare disorders like JMML, myelodysplastic syndrome, may not be cured without transplant. Vis-a-vis common indications for allogenic transplant in this population are aplastic anemia, Fanconi anemia, disorders like thalassemia, sickle cell anemia, and etc. So I would briefly, touch this.
Please remove your mobile nearby
I would
microphone.
briefly touch these disorders one by one. And first is acute lymphoblastic leukemia. Now, acute lymphoblastic leukemia, when we talk about this disorder in this population, we all know that these disorders have inferior prognosis, mainly because of higher prevalence of those genetic markers which would impart inferior prognosis, like Ph positive, Ph like, and other disorders. And that is why these patients at this age group would undergo HSCT more often for ALL. As far as indications are concerned, we all know that patients who have induction failure, patients who are MRD positive even after induction, and maybe reinduction, patients who have hypodiploidy and so on, would undergo allogenic transplants for ALL. The conditioning regimen, there is nothing much to talk about conditioning regimen, but what is more important is consideration of TBI. TBI everywhere is, I would say, inseparable part of conditioning regimen. Although much is talked about, that would be against TBI, because we are always concerned about short-term and long-term toxicities of TBI. But when we see this forum study, which actually looked into those patients who received TBI versus those patients who did not receive TBI, the results were better with TBI. And now in most of the patients who undergo transplants for ALL would receive TBI as a part of their conditioning regimen. Source of stem cells, till now, nothing has been conclusive. There are centers who would use use bone marrow harvest. There are centers who would use PBSC, but I think we are more comfortable with PBSC, although PBSC, peripheral blood stem cells, would lead to chronic higher rates of chronic GVHD, but it reduces the relapse rate, and I think it is safer for donor also. That is why most of the centers across the world as well as in India are more often using PBSC. Coming to the source of the type of donor, probably 15 years ago it was all match sibling donor, at the most mud, 100% match mud. But now more and more patients are undergoing haplotransplant. This is a recent study which I pulled out from a journal in 2021. And to my surprise, I mean, I was reading this article for the first time for this presentation. I found out that patients who undergo haplotransplant for ALL, of course, the population was heterogeneous, but good number of patients were less than 35 years of age. Patients who undergo transplant for ALL, haplo actually gave lesser GVHD, probably because of PTCY, which is not used in mud, which is not used in match sibling. The results for umbilical cord transplant were not very rewarding and promising. That's why most of the centers are not doing this. After ALL, going to AML, which is less common as compared to ALL in AYAs, this treatment modality, hematopoietic stem cell transplant, can potentially cure AML and MDS in AYA. But there is a word of caution here that most of these patients who have AML, MDS, the inherited bone marrow failure syndromes to be ruled out, because good number of patients, 1/3 of the patients would have some element of bone marrow failure syndrome when they develop AML or MDS at this age. Again, the source of donor, good number of studies are coming up, because only 30% of patients would actually have 100% matched donor. So remaining of them, 70% of them would undergo unrelated transplant or haploidentical transplant. And in most of the recent studies, the rate of GVHD, because GVHD and graft failure is the biggest concern with haplotransplant, but better techniques, better supportive care, and the use of PTCY, the rate of GVHD has come down. The source of graft, again, any particular center would use bone marrow, or other centers would use peripheral blood stem cell, depending on their convenience. The choice of conditioning regimen, the conditioning regimen has to be myeloablative. Most of the centers would use fludarabine, cyclophosphamide, etoposide in different combination. Some centers would add TBI. Again, the choice of regimen would be influenced by many factors like comorbidities, prior treatment regimen, and age of transplantation. So this is what has changed over last 20 years. Although the results for AYA still remains inferior as compared to their pediatric counterparts, but I think over years the results have improved. Third is aplastic anemia. It goes without saying that today the treatment of choice for anyone who is less than 40 years of age is match sibling donor transplant, and this is how the aplastic marrow is actually converted to a normocellular marrow. The rates of chronic and acute GVHD are acceptable. 90% patients would have long-term survival with match sibling donor at 5 years with universal engraftment. Again, it is very important to rule out inherited marrow failure syndrome at this age, because 50% patients would have some genetic marker which would favor inherited bone marrow failure syndrome. But the question still remains, only 30% donors, 30% of the patients would have full match sibling, because now we have one child norm. Patient may have a sibling but no match. So what is to be done in such cases? Again, good old friend, haploidentical transplant comes to our rescue. And I mean, the results may be controversial, many people may not agree to this, but good number of centers are offering haplotransplant. Again, a recent paper from Blood Advances, where the rates of overall survival, disease-free survival, chronic GVHD were comparable to match sibling donor. Having said that, MSD still remains the gold standard for aplastic anemia. Next is sickle cell disease. Not a very common indication, though in this part of country where we practice. As a hematologist who practices benign hematology, I have good number of patients who have sickle cell disease, but till now I have not referred any patient for transplant, because we have our friend hydroxyurea, which if taken in proper doses with good compliance, most of the patients would not need transplant for sickle cell disease. Sickle cell disease transplant is done for those patients who do not respond to hydroxyurea. It has been found that overall survival, disease-free survival is better when transplants are offered when patients are less than 18 years of age. It goes without saying that bone marrow as a source of stem cell is associated with better outcome because here we don't need GVHD. Conditioning regimen has to be myeloablative. Good number of centers across the globe, especially in India, are using the combination of triasulfan, thiotepan, and fludarabine because it is associated with good engraftment and almost 100% survival at the end of 7 years. Alternative donor strategies for sickle cell anemia are being explored. There is a type of conditioning regimen for haplotransplant with almost 70% long-term survival. Although this strategy has not been universal, most of the centers are not offering haplotransplant for sickle cell disease because it is an elective indication for transplant. Cord blood, theoretically, yes, because lesser chances of GVHD, easily available, that is questionable. No donor morbidity and decreased risk of transmitting viral infections. But in India, it has not picked up because we don't have public cord banking in India. But many questions when a patient with sickle cell disease has to be transplanted, where, which center, how, when. So many, what, when, why, and this still remains to be answered. Thalassemia is one disease where most of the patients, eligible patient, would be transplanted before they actually reach to this age. In fact, ideal age for transplant for thalassemia is 2 to 8 years, I think. But there are few centers which are doing transplant for thalassemia in selected adult patients who have been chelated well, who do not have hepatic fibrosis. But here the TRM, transplant-related mortality, can be up to 25%. So careful patient selection is very important here. Now, having seen, transplants in AML, ALL, sickle cell disease, aplastic anemia, thalassemia, there is one thing which is common with respect to AYAs, and that is propensity to have long-term effects. And that is why I think we are here to discuss how do we prevent this, how do we manage this. And there are 4 or 5 things which would need special mention when we talk about long-term effects of transplant. First is chronic GVHD, because when these patients survive longer, there are good chances that they would have chronic GVHD, they would need treatment for GVHD, and that would lead to considerable mortality. They are on treatment, long-term mortality. It would raise a lot of physical, psychological, and social challenges. So it is very important before we do transplant, we actually screen those factors which are avoidable and try to avoid chronic, although it is not, most of the factors may not be preventable, but it is important that we do vigorous screening for risk factors. And of course, after transplant, regular checkups are needed to prevent such conditions. This is very important for benign disorders like aplastic anemia, thalassemia, sickle cell disorders, because here we don't need GVHD. Second is second malignancy. We had a question in today's quiz that what is the incidence of second malignancies in the children who undergo transplant. Hematological disorders like secondary leukemias, myelodysplastic syndrome, the incidence is around 3.8 to 4%. It is very important that we screen these children for solid tumors like tumors of lung, breast, and cutaneous malignancies, because these malignancies, the incidence would go on increasing as they survive longer and longer. Fertility issues very important. Nowadays, it is pleasant to see that we are addressing this issue in a proper way. 2/3 of the patients who undergo transplant at this age, 15 to 29 years, would actually develop gonadal dysfunction. They might have infertility. That is why sperm banking, ova preservation has to be offered, although they may not be feasible in each and every case. The risk factor to develop infertility would depend on the dose and combination of cytotoxic drugs and the use of TBI. Use of TBI leads to universal infertility. Follow-up termination is very important as the patients as the time passes from the transplant. The follow-up termination rate would go on increasing. This is again from a recent journal taken from first world country. This is from Japan, where we see that this red line is for AYAs, and this is the population where we would see good number of follow-up termination. That is why these patients may have long-term issues. Last few slides, psychosocial effects. This is the most affected part in this population, but not well addressed. These patients may have difficulties in continuing their education, their occupation, vocational problems. These patients would have medical and social isolation that may lead to depression, anxiety, distress, poor quality of life. And the answer to this is multidisciplinary team management, which would have doctors, nurses, psychologists, social workers, because that is how this big problem, it's a huge problem, overlooked often, and multidisciplinary treatment of these problems can solve the issue. To conclude, I would say AYA, this 15 to 29 years is an important and diverse, biologically diverse subgroup of patients. Approximately 1/3 of all HSCTs which are done everywhere are done at this age. They have different medical and social needs. Due to better supportive care, OS has improved following HSCT. That is why we need multidisciplinary management to address this chronic and long-term issues, and that is the need of our. Thank you so much, TYAcan, because I think in most of the national conferences we have hematology, medical oncology conferences, this part doesn't get that much attention, and I think TYAcan is doing good work to bring out this. Thank you so much.
Thank you very much, Dr. Bahara, for an excellent talk. I am heaving a sigh of relief. The reason being that I'm a radiation oncologist and you still have so much scope for the radiation, total body irradiation and whole marrow irradiation to improve the survival rates. Efforts are on in United States of America just to reduce the, the importance of total body irradiation, but I think still stays afloat despite the tsunami of immunotherapy and so many molecules coming. So I think things are looking up. It's a wonderful presentation. The future is very, very bright. So with these words, I conclude this session, but of course you have to stay on for the Q&A session. So we invite the questions. Yeah, so invite the questions. Then of course, after that would have been. So we take the question, Professor Malhotra first. So we have the panel discussion first.
Yes, right after, and we'll save some time.
Yeah, so I've got the great privilege of inviting Dr. Professor Hemant Malhotra onto the stage to conduct the next proceeding. Always a pleasure, sir, to meet you at various fora. And I learn a lot because I attend your webinars also. Welcome.
So thank you very much. Always a pleasure to be here. And I've been in this hall. This is my third or the fourth visit. And out of the 11 conferences with Colonel Chitalkar has done, I think I've attended 10. Maybe one I didn't attend, right? So again, a pleasure to be here. And before I start, I'd like Colonel Chitalkar to come here and all of you to give him a standing ovation. Thank you very much. Thank you, Prakash. I've known Dr. Chitalkar for more than 30 years now. We worked together in the 1990s at Tata Memorial Cancer Center. We learned medical oncology together. And then in 2012, when he did the first conference in Faridabad, I was very much there. And since then, as they say in the Forge, I have a very dear friend at TMH, Gaurav Narula. He was in the Navy. And the motto of his regiment was bash on regardless. So Colonel Chitalkar, he follows that and he is bashing on regardless because he's so passionate about TYA. So hats off to and salutes to Colonel Chitalkar. So if we could now move on to the panel discussion, we have a nice mix of okay, so you can see the panelists on the screen. Dr. Ankit, are you there? Are you going to answer questions online? Ankit, are you there? So can the IT people please try and see if they can connect Ankit online? And then we have our two speakers of the morning session, Dr. Vinay Bora and Dr. Sumit Lokmani. Can you please come here on the first sofa? Can somebody give them a mic, a cordless mic on that sofa, please? Thank you. Is Dr. Swati Patel here? Yeah, please come here. So Swati is assistant professor of hematology oncology here at this institution. Please join your colleagues over there. Thank you. Is Vijay going to be present?
Yes,
Okay,
I'm
Vijay,
here,
are you
doctor.
there?
Yes,
Vijay,
I'm very
are you
much
there?
here. Thank you. Yes.
Wonderful. Thank you. And do we have our two survivors, Mr. Dilip and Mr. Yash? Ajay? Yes. And Mr. Yash Sahu and Chahat? We have all the four of you are here, or are you going to attend online?
Should I go there?
आ जाइए इधर आ जाइए प्लीज आगे वाले सोफे पे यू आर द रीजन व्हाई वी आर ऑल हियर
वहीं चली जाती हूँ हाँ मेरा ही वहाँ कोई आ गया तो
आइए बेटा उधर आइए उस सोफे पे आइए प्लीज
अंदर जाते हैं बंद ना
डू वी हैव अनदर कॉर्डलेस माइक
यहाँ
फॉर दीस
पे
पीपल
कनेक्शन नहीं आएगी
दोनों को शेयर करें सो कौन है विद
कनेक्शन नहीं आएगी अंदर
So Ankit, are you there? Ankit, are you connected? Okay, let me ask the first question to Dr. Vijay. Mrs. Vijay Venkatesh, or everybody calls her and knows her as Amma. So Amma ji, are you there?
Yes, very much here, doctor. Very much here.
So
Yes.
tell me how many patients of CML between the age of 15 and 30 who qualify in the TYA group do you have presently on the GPAP program?
We would have definitely more than say around 30%, 28% of the total number of patients in the Max Access Solutions program. So I would be looking at about 1500 plus.
So 1500 TYAs in the GPAP program.
1500 plus.
So those of you who don't know is the GLIVAC International Patient Assistance Program, which is run by the Max Foundation, in which free medication is given to them through a collaboration between Novartis and Max Foundation. So Vijay, can you tell us what are the special problems which you encounter in this particular population? Is the non-compliance rate higher in this group of patients, or any other specific issues which you face?
What is very important for these patients in this age group is that there should be no disturbance, there should be no disruption in either their scholastic life or in their personal social life. And unless they have the support of their parents and the family, this is a little difficult for them to achieve. So what the biggest challenge we have found is actually not non-compliance, because these are young boys and girls who are very, very aware, and they make an effort to attend all the patient support group meetings, but they do have a challenge in which that they come from, a lot of these patients come from financially challenged backgrounds, and their parents are not able to give them the kind of support which the parents themselves would want to give. We do have patients from a slightly higher socioeconomic level. There we have found that there is a lot of awareness, there's a lot of support, and a lot of these children are unable to share the diagnosis in their school. Some of them do, a lot of them don't. So these are the main challenges we find. And in a way, I think there's a lot of unquestioning acceptance in these young patients. And that gives them a lot of energy, a lot of positive energy to go ahead and do what they have to do.
Thank
In
you,
fact,
Vijay. Thank you very much. I think we have very little time and quite a few questions to do. So thank you very much. I'll come back to you in a little while. So now I'd like to bring in our 4 cancer survivors. And again, a big round of applause for all these 4. आपके पास माइक के साथ सबसे पहले मैं आपसे शुरू करूंगा. ये 3 डॉक्टर्स जो हैं ये आपके ट्रीटिंग डॉक्टर्स हैं. जब आपको डायग्नोसिस हुआ तो आपके दिमाग में सबसे पहला प्रश्न क्या था? What was the thing which bothered you the most? हाँ, वहीं बैठो बेटा, वहीं बैठ के आराम से जवाब दो. Okay. So, do we have enough chairs for all of them? चलो 2 जन जो गाइस हैं वो स्टूल पे बैठो. चलो आ जाओ यहाँ पे. लड़कियों लोग कुर्सी पे बैठो और लड़के लोग पीछे स्टूल पे बैठो. आ जाओ सब लोग इधर आ जाओ स्टेज पे.
जब मुझे डायग्नोस हुआ तो एक्चुअली मेरा
बैठ जा आराम से बैठ करके रिलैक्स करके.
थैंक यू. एक्चुअली जब डायग्नोस हुआ तो मेरा 1.25 साल का बेटा था. तो मुझे ये नहीं था कि मुझे कैंसर हो गया है, अब क्या होगा. मेरे दिमाग में बस ये था कि जो बच्चा मेरे बिना 1 मिनट नहीं रह पाता है, तो अगर मुझे कुछ हो जाता है तो उसका क्या होगा. बस एक वही चीज थी जो मुझे बहुत ज्यादा डराती थी. और दूसरा ये कि कहीं मेरी डिजीज की वजह से उस पे कोई उसके हेल्थ इश्यूज कुछ ऐसा ना हो, तो वो मुझे बहुत डर लगता था. जो डर अभी तक भी, अगर वो उसे थोड़ा सा फीवर भी आता है तो मैं ऐसा कि नहीं से फीवर क्यों आ गया, पर डॉक्टर्स कहते हैं इट्स नॉर्मल, बच्चों को फीवर आता है. बट उसे मैं कनेक्ट करने लग जाती थी कि कहीं ये मेरी वजह से तो उसके साथ ऐसा कुछ नहीं हो रहा है. बस यही एक डर था सबसे ज्यादा.
चलो पलक, तुम बताओ, जब तुमको डायग्नोसिस हुआ तो तुम्हारे माइंड में सबसे बड़ा क्या क्वेश्चन था? नंबर 1 इशू विच यू हैड, सबसे इम्पोर्टेंट, सबसे बड़ा क्वेश्चन क्या था आपके माइंड में?
मुझे इस बीमारी के बारे में कुछ पता नहीं था, तो यही था कि ऐसा क्यों हुआ, क्या होगा. पर फिर बाद में जब पता चला कि सब डॉक्टर से मिली, सब पता चला कि इसका इलाज है, तो फिर कोई क्वेश्चन नहीं था.
अच्छा, अभी तुम्हारा ट्रीटमेंट पूरा हो गया, अभी तुम्हारे माइंड में क्या क्वेश्चन है? डू यू हैव समथिंग व्हिच यू वांट टू आस्क योर ट्रीटिंग डॉक्टर कि डॉक्टर मुझे इस सवाल का जवाब दो?
नहीं, अब मुझे कोई क्वेश्चंस नहीं है.
क्या बात, व्हाट अ वंडरफुल पेशेंट, आइडियल पेशेंट. ओके, सो वी हैव दिलीप एंड यश, राइट? चलो आप पहले दिलीप, हाँ, यश एंड यश. ओके, सो यश साहू एंड यश यादव, राइट? सो यश यादव, पहले आप मुझे ये बताओ, आपके माइंड में जब डायग्नोसिस हुआ आपको तो क्या डर लगा आपको सबसे ज्यादा?
सर कुछ नहीं सर, वो थोड़ा माइंड
यश खड़े हो जाइए प्लीज.
थोड़ा माइंड डिस्टर्ब हो रहा था और मालूम नहीं पड़ा, गले में से पता चला तो जब जाके मालूम पड़ा चेक करके.
अच्छा, फिर जब ट्रीटमेंट हुआ तो क्या ज्यादा दिक्कत हुई? उल्टी ज्यादा होता था या बाल झड़ गए थे तो लोग मजाक करते थे, क्या प्रॉब्लम हुआ?
सर प्रॉब्लम तो कुछ नहीं हो सर, हालत सर वैसी हो गई थी, कमजोर थोड़ी.
अच्छा,
बाद में जरा मालूम पड़ा था.
अच्छा, और अभी बिल्कुल ठीक हो, स्कूल जाते हो?
यस
हाँ?
सर.
कोई गेम्स खेलते हो?
यस सर.
वंडरफुल. दूसरे यश, ओके, वंडरफुल. हाँ जी,
यस सर.
आप बताओ यश, अब जब आपको डायग्नोसिस हुआ था तो कुछ डर लगा था क्या?
जब डायग्नोसिस हुआ था जब तो मुझे पता ही नहीं था इसके बारे में कुछ, जब बहुत छोटा था मैं जब.
हाँ.
उसके बाद धीरे धीरे पता चला.
अभी कोई माइंड में प्रश्न है क्या? अब कभी कभी सोचते हो बीमारी वापस तो नहीं आ
हाँ,
जाएगी?
वापस तो नहीं आ जाए इसका डर रहता है हमेशा.
डर रहता है?
3 बार आई है वापस क्योंकि.
अच्छा, चलो, वेरी गुड, कीप फाइटिंग.
Doing bachelor's in music, and I think he began the conference by playing on the thing, and we would like him to keep playing again and again.
So let me ask our transplanter, Dr. Vinay Bora now. Vinay, when you have a patient like this, How do you counsel them for fertility preservation, and how many patients come on board for fertility preservation?
So I would categorize them into two categories. There are patients who come with fulminant disorders like acute leukemia. There, I think time doesn't permit us to consider all these issues. But then there are patients who come with some sort of semi-elective where we can wait for a few days. So especially in females who are into 15 to 19 years of age group, there I make sure that I counsel their parents because I think at this age, 15 to 19 years, these children may not be receptible to fertility issues. They might understand, but the issue which I face in my practice is they don't speak much. So they are more concerned about their disease. There is a lot of anxiety. When they enter cancer hospital, they read that board.
So when you talk to their parents about the treatment and the chance of infertility and uncorrectable infertility, what is the reaction of the parents?
So when it comes to male child, parents do not have much concern. That is my practical experience. For females, I think most of them would want to have fertility preservation option.
Okay, so I'd like to ask Swati now. Swati, you're a pediatric oncologist. We have moved a long way in treating acute pediatric leukemias, and all of us work in a resource limited situation. So, and a whole bunch of genetic markers are being described now. So in your opinion, for both ALL and AML, can you tell us a minimum panel of genetic aberrations in which we should look for every patient? In every patient, we should look for those, keeping in mind the middle income country we are, and keeping in mind that most of the support programs of the government in most of the states, at least in my state in Rajasthan, part of the treatment is covered, but investigations, detailed workup, NGS for all patients is not covered. That is out of the patient's pocket. So what minimal panel do you think should be done for acute lymphoblastic leukemia? And what minimal panel should be done for acute myeloid leukemia?
So thank you for the question, sir. So for ALL, so basically in a resource limited settings, we want to risk stratify based on the cytogenetics. So we would like to identify the high risk patients based on the cytogenetics. It is
so you think that a karyotyping should be done for all
Yes,
patients?
yes.
Minimum.
Yes.
And
So-
you work here in Indore. Can you do it in house or do you have to outsource?
Right now we have to outsource, but we have very good system right now to outsource it also. And we are able to send the samples within time, and we are able to get good reports. So a karyotyping, and for ALL patients, a BCR-ABL, mostly it is identified on the karyotype, and MLL translocations for pediatric cancers. And if possible, then for this one, for the AMLs, I would like to do an MLL, BCR-ABL also, and a karyotype. This is the minimum. If we are able to do more, that is obviously better, but this is the minimum that we would do.
And 15, 17, you want to make sure that we're not missing a 15, 17, right?
Sir, unfortunately, we will miss in some cases,
Yeah.
but it's not covered in the majority of panels also that we have. So having said that, I would like to say that as oncologists, as the medical fraternity, it is our responsibility to push to our government. It is our responsibility to tell our governments that these are necessary tests, these are required tests, and we have to get funding for all these tests also.
And I'd like to also, expand on that. And, my wish list would be that each teaching and training institution should have in-house minimum a karyotyping and some basic fish panel for both acute and chronic leukemias. I think that again, our directors, our senior administrators, we should convince them that we should be able to do at least a minimum panel in-house, right? Agreed?
Agreed.
Okay, so let me ask Sumit now. Sumit, very nice talk. For a patient who has stage 4 Hodgkin's disease, would you still give that patient no resource constraint, ABVD, like you said, ABVD, anything better than ABVD on the horizon?
So
First
when-
line de novo, newly
Sir,
diagnosed patient.
I mentioned escalated BCOP being given in special situations. Patients with stage 4 disease having multiple organ involvements are candidates for BCOP and escalated BCOPs as well. And my first preference here also will be given the comorbidities if they are there at all. Escalated BCOP takes a back seat and ABVD takes a front seat there. So it is individualistic to say that what we go for. But on a general note, if there is no multiple organ involvement, patient is a stage 3/4, I would still go for the ABVD part, sir.
So I think for the information of our younger colleagues, particularly Colonel Chitalkar's third years who are going for their DM practical exam in a few weeks' time. Last month, there was a publication in NEJM in which first line brentuximab was compared with ABVD, and we did discuss that on our one of the virtual forums also. And for the first time in 15 or 20 years, we have a first line regime which in a randomized trial has been proven to be better than ABVD. We don't have brentuximab available in India, horrendously expensive. And Sumit already highlighted that very clearly, but theoretically speaking, science-wise, we may have brentuximab, doxorubicin, minus the bleomycin, ABVD minus bleomycin regime, which in high-risk Hodgkin's, patient with high IPI and stage 4 Hodgkin's might be better than ABVD. Okay. So I have another question to Swati. Swati, for a 22-year-old acute lymphoblastic leukemia patient, would you treat that patient on a pediatric protocol or an adult ALL protocol?
So, sir, the AYA patients, they fare much better with the pediatric protocols compared to the adult protocols, and the toxicities are a little higher but manageable. But the outcomes are excellent with the pediatric protocols. So, 22-year-old, I'll treat with the pediatric protocol.
And what about the toxicity and the significantly increased expenses?
Yes, sir. So that is there. So toxicities, some toxicities that we know which are more, where we can modify the protocols according to the age and according to the toxicities that the patient is experiencing. And there comes the role of the treating physician. And expenses, of course, there are so many organizations that are helping, the Ayushman Yojana and the CM Fund and other schemes which are helpful. And apart from that, crowdfunding has really increased our horizons. So all those things are there, and apart from that, we try to manage in whatever funds we have.
And have you shifted completely from regular aspergillus to PEG aspergillus, or do the majority of your patients still get regular aspergillus?
So majority of my patients are still getting regular asparaginase. And if they develop any allergic reactions, then we are giving PEG asparaginase. Where we have the facility of any government scheme, or where we are able to procure the pegylated version, there only we are giving pegylated.
So my next question is to Dr. Vinay. Vinay, do you have facilities for cryopreservation in your center for stem cells?
No, sir. Currently, no. That is why we cannot do Hodgkin. Ideally, we are not doing.
So lymphoma transplants are difficult.
We don't have it here. We have to outsource it. There are some organizations, commercial companies, which are coming from Delhi and doing it for us, but we don't have it in house.
You don't have it in house.
No.
So we are a new transplant center also, and we keep consulting Colonel Chitalkar on our transplant program. We've just crossed the number of 12 transplants at our center. Yeah, please.
Yes.
It will require about 6 days cryopreservation, and that's actually pretty simple. And we've been doing it on our own, and it's an unstructured manner, but it's successful. And there is loss of cell viability, not much. I mean, we get engraftments in 10 to 12 days. So I think it's possible with the EMS or next and just kept it to say minus 40 degrees or something like for 7 days. It's pretty simple. So it's possible.
So what about haplotransplants? Are you contemplating doing haplos?
So I did this region's first haplo in 2017. It was a pediatric patient, high risk ALN. That patient relapsed at 6 months. I did second haplo for 21-year-old aplastic, but he had fulminant HLH 60 days into transplant. Third haplo, again HLH. So I've stopped doing haplos. And in fact, I refer my haplos to Chitalkar sir because they have a bigger team here. They can better take care of patients. So I'm not doing haplos.
Okay. So we have the three experts here in front of you. If you have any questions, audience, any questions, any comments on their talks or some aspects which they did not cover. Madam Kurkure, you have any comments to make? Tell us about minimum testing for acute leukemia in a resource constraint settings. Tell us about the effectivity, costs, ups and downs of using pediatric protocols, ALL protocols in a 20-year-old patient with ALL.
I would say, can you hear me?
Yeah, if you get a little closer to the mic, we'll be good, ma'am. Please go ahead.
You have covered, Swati, and you have covered most of the things as to it has to become mandatory to do those certain tests in-house for every patient. We have to convince the authorities that it is an investment, because if we do the correct risk stratification, we can escalate therapy for larger proportion of patients who fall into that risk. Generally, majority of them are into standard or intermediate risk, and very small. In AY, it will be higher, around 15%, but otherwise it's a very small proportion in pediatric age group. So you don't have to treat everyone with the higher treatment protocols, and it is a sort of an investment for that, because you have to feel confident to escalate the therapy. So that is the first point. And second, which I would say, is that same thing holds true. Like if you have the infrastructure in place, then only you will be able to follow them up with MRD, which has superseded all the risk stratification criteria today. So I think you cannot do outsourcing is good enough first time. But if you have to do repeatedly, then the consistency in the test is very, very important. And the MRD is the most crucial thing, because we also outsource at SRCC because the number being small, it is not cost effective. But I think all the people who are into this practice, they should get together and have some central place where you can have a dialogue. At least in Mumbai, we are fortunate to have a good private laboratory of Dr. Saikel, and we have a communication, because MRD is really googly. Many a times you have to have a proper dialogue with your lab to understand very marginal MRD levels and so on. So this is a very, very important. Secondly, the comment about the haplotransplant. I think haplotransplant is more you do, better you become. And to start off, it is better to invest into the alpha beta depletion haplotransplant so as to minimize GVHD rather than only, and PTCY, but you have to be prepared for all the problems of GVHD. So the kit is very costly, and that is how we try to cut corners and not do the PTCY. But if we have to start off haplo, it is always better to start off with those haplos where you can do the alpha beta depletion. And then because alpha beta depletions, they really do well. And results of haplo is very good in a relapse setting, because you have the GVL effect. So it is a question of getting used to it and manipulating your structure, infrastructure to tune with the requirement.
Yes, Prakash, you have any comment? Please go ahead.
I think we came up with suggestions so far about basically advocacy about how to incorporate the cytogenetics karyotype in the initial workup. The big problem is now, as you said, in Rajasthan, Madhya Pradesh, all states, the treatment is being covered. The workup is not covered. And as ma'am eloquently said, It's a huge investment if the workup is done properly and we can re-stratify the patient on day one. So I think now we have a forum in the National Cancer Grid. And I think the National Cancer Grid has the experts which ultimately have an impact on the National Health Authority. And they are the ones who start the, improve the Ayushman protocols periodically. I think we should also, maybe as TYAcan, we should make recommendations to National Cancer Grid expert forum and try and incorporate these tests. I will also introduce little Khushi. She's 13-year-old. She's had a transplant for aplastic anemia under Ayushman. So this is one center which is actually doing transplant under Ayushman. And we had at least 3-4 of them. So her sister, elder sister, Manisha, she gave her stem cells, and Manisha's preparing for to join the police, by the way, elder sister, and she's finished. She's passed her day 120, and she's 100% donor chimerism and doing excellently. And she's from a little place called Badwani, which is on the banks of Narmada over here. And I mean, amazing, complete remote location. Apparently, there are boats which you need to cross the Narmada before you reach their home. So we are living in that world, but we thanks to Ayushman Bharat, we are able to do these things now.
Wonderful. I think these are the small sparks which keep us alive and which.
हमारे प्यारे प्यारे सर मैडम ये सब हमारी बहुत सारी सहायता करते हैं और हमारा आयुष्मान खत्म हो गया था हमारे चितालकर सर पुता में स्वाति में ये सब ने हमारी सहायता करी जो ये सब जिसका जो काम करते थे उनमें से हमें गोली दवा ये सब दिलवाई नमस्ते
So any questions, comments from the audience? Vinay, you want to make a comment?
As Madam said, probably for our center, with respect to my center, we would try and see how we can start doing haplo, because I think haplo is the future. So
Sumit, any take homes from your side with regards to your topic and with regards to hematological malignancies in the young patients?
So the only take home which I would comment on after listening to so many people and so many seniors like you and ma'am and sir and everybody, please don't ignore any lump in your child, any abnormality. मुझे कमजोरी लगती है, इस statement को नकारिए मत. And please pay attention to your kids and wards. The young and teenage population, वो ऐसा वक्त होता है जो अपने में खुद ही ध्यान नहीं दे पाते हैं. So that's the time I think we should support them as elders, as seniors, as brothers and sisters and cousins and moms and dad and everything. So the take home from here will be just be vigilant. That's all. That's all I can say, I believe. And I'm too young to say that, but so that will be my take home from here.
Very, very well said, Sumit. Swati, any final words from your side before we wind up?
I'm a pediatric oncologist, sir. So all my patients who win this fight over cancer, they develop into adolescents and young adults, and I think a survivor is the best person to do advocacy for cancer awareness. And I would like to just salute all the survivors that have come here and that have gathered the courage to face cancer again in another way.
All right. So with that.
Yes, definitely. Definitely.
Yeah. So they are the spark which keeps us going. So with that, we finish this panel discussion and this session. Thank you very much all for your patient hearing. And let's give a big round of applause to our cancer survivors and our cancer crusaders.
Thank you very much, Dr. Malhotra, all the panelists and everyone. I think it's been an amazing experience sharing on a single platform. There's a small video about the support to a support system for aplastic anemia patients.
Presenting Asha, an initiative by BSV with you. When an aplastic anemia patient comes to see you for treatment, after the consultation, tell him about our Asha initiative and give him the kit. When a patient receives the kit, they connect on our ASHA toll-free number. Post connecting with our ASHA executive, the patient is given a thorough explanation of ASHA and its services. ASHA offers 3 different services: patient counseling, patient assistance, and financial assistance. On selecting the services by the patient, ASHA's executive sends the patient a link for sharing the essential details via WhatsApp. After filling in the required details, the patient will receive an acknowledgement along with patient enrollment ID. Being the patient's doctor, these details will be shared with you by ASHA. Our 3 services are as follows. Service 1, Patient Counseling. This service is rendered to every patient who reaches out to ASHA and is interested in the program. If a patient has selected Service 2, that is, Patient Assistance, ASHA's executive informs the patient about the required documents, that is, the treatment as per the doctor's prescription and request letter for 10% units of total prescribed TYAcan therapy and 3 alternate months on cyclotherapy to be given free of cost. Once the patient has shared the required documents, ASHA's representative will deliver masked samples free of cost to them. Post-delivery of samples to the patient, you being the patient's treating doctor, ASHA's executive will update you about the delivery status via message. If a patient has selected Service 3, that is, financial assistance, then ASHA's executive will call the patient for the required documents. Post-verification and loan approval, ASHA's representative will hand over the prescribed TYAcan therapy units to the patient and send the patient a message to confirm the same. You being the patient's treating doctor, the ASHA executive will update you about the delivery status via message. Doctor, you are the only one who has helped patients in recovery from aplastic anemia. We thank you for this. With this program, we at ASHA aim to bring a ray of hope to aplastic anemia patients.
Recently, I was reading something, so I came across beautiful lines about cancer, which I would like to share with you. Ultimately, they are just breasts, right? I mean, I love them. They are mine. They are beautiful, but in the grand scheme of things, I would rather be alive and would rather grow old with my husband, family, and friends. With these lines, let's move on to our next session, which is on young woman cancer, and for which I would like to invite Dr. Namrata Kachara, Senior Consultant, Professor of Gynec Oncology, Sri Aurobindo Medical College, Indore. May we have you, ma'am, as a chairperson. So much. Dr. Namrata Kachara is a chairperson, and the speaker for this, we have Dr. Jyoti Bajpai, who's on the way, it seems. She's not online, she'll be joining. So, okay. So let's have her. Ma'am, are you there? So she's the first speaker, Dr. Jyoti Bajpai, Professor of Medical Oncology, Tata Memorial Hospital, Mumbai, President of Indian Society of Immuno-Oncology, also Joint Secretary, TYAcan Foundation. Ma'am, can you hear us? Ma'am, are you there?
So, yeah, hello everyone. And at the outset, I would like to thank Dr. Chitalkar and other organizers for this invitation to present in front of you for this TYAcan and for a very important and relevant topic, which is really, really close to my heart. It is a special issues and approach in young women with early breast cancers. And next few minutes, we shall be talking about what is unique about this special population, how we deal with it. So I will begin with a important movie, which I'm sure many of us must have seen. It is List of a Lifetime. And in this particular movie, diagnosed with the breast cancer, a young woman, she decided to have a bucket list of her own, facing her own mortality. Brenda Lee, who's diagnosed with triple negative breast cancer, reunites with the daughter she gave up for adoption as an infant. And together they set out to accomplish everything on their bucket list, no matter how wide it is. Until she suddenly finds a coupon for free wings at Buffalo Wild Wings. And after fantastic lunch, they head out for an amazing adventure through the woods to find grizzly bear, mountain lions, and breast cancer, of course. So this is not really different from the real world story. And many young women, when we come across in our clinics, we see they diagnosed with this, very frightening and stigma kind of a thing in their life, and then life suddenly moves from very active, career oriented or homemaker, but very strong young woman, mother, etc., to a breast cancer patient. So this transition is very difficult, very challenging, and encompasses many trajectories which we need to deal with very sensitively. And they are worried, they have many desires, outcome-oriented, quality of life, fertility, pregnancy, and many more. So in this few minutes talk tour, we should be discussing about what is the current breast cancer in young guideline statements, specific issues like overtreatment, psychological distress, hereditary predisposition, body image issues, inadequate representation in trials. Then what is TMH data on young breast cancer, triple negative breast cancer, and pregnancy associated breast cancer, fertility preservation strategies, embryo oocyte cryopreservation, cryopreservation for ovarian tissues, and temporary preservation with GNR Genlock during chemotherapy, pregnancy after breast cancer, and pregnancy with breast cancer. And then, of course, a TMH data on PABC and conclusions. So this is the ESO-ESMO BCY guidelines, and they highly emphasize that targeted clinical trials to address specific issues are really lacking. One need to really concentrate on fertility issues, psychosocial support, and genetic counseling for this young woman, and of course, a sexual quality of life, which is often neglected, not even talked about. Then also, it says very loud and clear that treatment determinants are biology, stage, genetic predisposition, comorbidities, patient choice, and age alone should not be taken as one reason so that we overtreat, we treat more aggressively to them. We should avoid overtreatment in these women because it having very dreaded effects on quality of lives. So next we shall be discussing about psychological distress. So psychological distress can be due to multitudes of reasons. Hereditary breast cancer disposition is more common among young women and may influence decisions on both local and systemic disease management. Women with an identified germline mutation also need to tackle the additional challenge of future cancer risk, and they may undergo risk-reducing surgeries, counseling for those, cascade family risk assessments on multiple times, pre-implantation gestational testing, chemo-induced alopecia, which is again a dreaded complication, stigma, which one has to deal very sensitively. And all these decisions are often accompanied by extra psychosocial distress and dealt sensitively by experts, preferably in multidisciplinary tumor boards. We can offer them the best remedies. There needs to be dedicated genetic clinic. And also I'm an advocate that we should be having dedicated young breast cancer clinics as well. So this is one of the randomized trial from our own TMH group, wherein we did conducted randomized control trial of scalp cooling for the prevention of chemotherapy-induced alopecia, and we found that with these sophisticated systems, there is successful hair preservation in women who used in every cycle this kind of device versus those who do not. And this is consistent with the results from recent studies which show success of scalp cooling in 30 to 80% patients, depending upon which kind of chemotherapy combinations is used. And we have used anthracycline and taxane both, which is the main backbone for these kind of cancers. So this is again assurance that we can preserve these women, their lives as well as their dignity, and we can preserve their hairs, we can preserve their breasts, etc. So this is the picture baseline at primary endpoint, the scalp cool patient, and you can see the drastic difference with the controls. Then we have done a registry study in a large number of patients, and our first data from this study, which is unique challenges and outcome of young women with breast cancer from a tertiary care center in India. And this is a large number of 1228 patients in 2 years time period who were treated with curative intent, non-metastatic plus oligometastatic disease were included. And this is the baseline characteristics. So you can see that our young breast cancer are higher than that in the Western population, maybe due to the age pyramid itself, which is much more younger in our part of the world. And among them also 50% are less than 35, which constitutes very young breast cancer patients. They are having aggressive biology. They are having higher T size at presentation, 50% present in stage T3, 4. They are lymph node positive 75% of the times. Then 30% are having N2, N3 disease, higher grades. Stage 3 is having 56%. Then TNBC is 34%, and HER2 positive 27%. Multimodality care, so 50% breast conservation surgeries, 80% radiotherapy. All hormone receptor positive receive hormone treatment, 9% OFS. Additionally, chemotherapy predominantly anthracycline and taxane based, 6% grade 3-4 toxicities, and 2 chemotoxic and 1 post-operative death were also encountered. So anti-HER2 were 54% eligible population, and half of them actually received short course. It is slightly older data. Now there are much more women who can afford HER2 positive therapy with the advent of generics as well as many government patient-friendly schemes. So this is the consort, and we can see that they are predominantly in stage 3, which is again an alarming thing. We see our young women who present in their locally advanced stage rather than an early stage till today. The survival analysis, so 5-year survival of EFS around 59.1%, OS 79%. And this is a stage-wise survival, and we can see a drastic difference when they diagnosed early stage, stage 1, 94%, stage 2, 65.9%, 3, 10% fall, 55%, and 4, this is oligometastatic disease, 29.6%. So this again underscores the need to diagnose them early and treat appropriately. This is a multivariate analysis for DFS and OS, and it shows that older age, relatively older age, because these all were young, but relatively older age, low T end stage, absence of LVI and PCR were associated with superior outcomes, while hormone receptor status were associated with superior OS alone. So when we did a comparison between very young versus young, so 35 years was the age cutoff for this comparison, and we found that very young breast cancer, that those less than 35, were associated with low PR expression, high NSCT use, higher LHRH agonist use for fertility preservation, etc., which is matching with the data which is published. Now, their fertility-related concerns. So, fertility-related pregnancy-related concerns and issues are one of the top 3 priorities for young women with breast cancer. I mean, this is very much highlighted in the guideline statement for BCY, and not only fertility pregnancy related concerns, they actually can predict outcomes as well, and demographic, medical, and psychosocial characteristics plus disease and treatment variables. They can predict unique biological and behavioral outcomes, and which is very, very important. They are having bearing on quality of life, menopause and fertility and behavior. So failure to address these concerns may negatively impact on patients' outcomes. And there is enough data, what we are seeing, that early discontinuation of tamoxifen intake in younger women with breast cancer can lead to poor outcomes, and non-adherence to homotherapy can also, seen as a negative prognostic marker. Many women who could not complete their families and they diagnosed with breast cancer, they are having this dilemma. So we need to very judiciously and efficiently deal this issue, and if at all they can be carefully interrupt their therapy in between under strict medical oncology supervision, then they need to resume back in a short span, and then we will discuss this part later. But this is a very important feature. So this is a risk of treatment-related premature ovarian insufficiency in breast cancer patients, and determinants are age, chemotherapy regimen, and cumulative chemotherapy dose. We are seeing these are the most common regimens, and high risk associated more than 80% risk for infertility are majority of the anthracycline-based regimen what we are using today. So oncofertility counseling is mandatory as soon as possible after diagnosis. This is even ESCO updates. And one important paper, which was by my dear friend Matthew Limbertini, physicians' knowledge and attitudes towards fertility preservation in cancer patients, suggested that 50% of the physicians are not having good knowledge, which is again alarming, and really it's food for thought. We need to work on this very important aspect. So this data suggested that only 80% of oncologists actually refer patients for fertility preservation, although they are aware about the things. Most, like 76%, they are aware about where to refer for semen cryopreservation, but only 46% about ovarian cryopreservation or other complicated procedures like sperm extraction. Only 30% alter their systemic treatment for breast cancer for fertility preservation reasons. So they do not find it so much important. So how we should approach young breast cancer in current era? If we need to assess the risk of gonadotoxicity, wish to preserve fertility, a woman needs to be counseled and asked very carefully. And if it is yes, then we need to see that what is the time available, how aggressive is the cancer, and if it is more than 2 weeks available, which is the case in majority, then ovarian stimulation is a safe thing, and oocyte embryo cryopreservation after that. And then GnRH during chemotherapy to support further. If it's less than 2 weeks, then ovarian tissue cryopreservation is the option. If it is no, then also ovarian function preservation can be discussed, and GnRH analog during chemotherapy can still be an option. So what does our own data suggest with regard to fertility preservation pregnancy? So it's patchy data because being retrospective, we could not obtain the data in all patients. So majority of the receive some kind of fertility preservation counseling. However, there's lack of documentation and details available in only around 30%. 45% among those are having significant PMS, sleep disturbances, memory problems, mental exhaustion, mood swings, hot flashes, vaginal dryness, effect on sexual quality of life. And they're much more prominent when we are giving tamoxifen along with GnRH suppression, so dual hormone. We need to be carefully choosing these kind of therapies in young women and after appropriate counseling. So 9% received LHRH agonist, and among them 35 nulliparous, 85 desirous of second child for fertility preservation, and 39% women conceived post chemotherapy. 28% had live births, latency range of 2 to 7 years after treatments. This is very important data, although it's not complete, but it still suggests that these things are possible if we carefully counsel our patients and support them throughout. And what about pregnancy after breast cancer? So breast cancer patients have a lowest chances among cancer survivors to have a subsequent pregnancy because of multitudes of reasons. Their borderline age, and this analysis is adjusted for education level, previous pregnancy and age. We can see that thyroid, melanoma, Hodgkin's, etc. are much ahead, while breast cancer goes down. Again, due to the age when they diagnose, it's generally a borderline age to getting menopause. So then this was a survey which was done that may a pregnancy in breast cancer survivor increase the risk of recurrence, and it was checked in BRCA mutated versus normal patients, and it was found that in both ER positive, ER negative, including BRCA positive patients, it was found to be safe to have a pregnancy after breast cancer. This is a very important study, positive study, which I was discussing in the beginning as well, that pregnancy after breast cancer and safety of interrupting therapy, hormone therapy for women who want to become pregnant in between. So this is again found, this is a very important study, carefully chosen till 2 months, they allow to interrupt and then again resume the hormone treatment. And I think the final results will enlighten us for many things. But so far, this is one of the ray of hope for this kind of women. Pregnancy with breast cancer. So this is very, very important topic. And PABC is defined as breast malignancies diagnosed during gestation or till 1 year postpartum. And there are new suggestions for extended time period as well in postpartum, and also to differentiate these two with pregnancy during breast cancer is entirely different thing, and postpartum are different thing because the approach and connotations are different. So what is the epidemiology? And this is a graph showing that rate is, although it is rare, but it is rising. And the documented incidence say 1 in 3,000 pregnancies. The reason for increased incidence is that delaying of childbearing to a later age, increasing incidence of cancer with age, increasing number of premenopausal women diagnosed with breast cancer, and better detection and increasing awareness as well. So it it provides cancer care to pregnant women with equal emphasis on fetal health is a daunting task. And additionally, lack of cancer awareness, limited expertise, and resource lead to a delayed diagnosis majority of the time. Additionally, in India and other low middle income countries, there is inadequate access to healthcare, infectious diseases, socio-cultural practices, and which contributes to higher maternal and infant mortality. So we need more information. There are limited registries worldwide, and we need them definitely. There was no data from India prior to our TMC study, and this is the first Indian registry for PABC, and now we extend it to, apart from breast cancer, all other cancers as well. So this is our first data from this gestational cancer registry, and we found that there are around 104 patients till that time. Now they are crossed 115, and in this considering such a rare disease, this is a very good number. And we found that antepartum they were 34, postpartum they are 70 as comparable to the world literature. And we found that all the children till last follow-up, they were experiencing normal milestone, which is very assuring, except one premature infant which shown some delay in acquiring milestones. So again, emphasizing that prematurity should be avoided for unless there are pressing obstetric reasons. So every week adds to cognitive development and attaining of milestones normally later in life. These are the baseline characteristics. So families to breast cancer present in 24%, while median duration of symptoms is 6 months, 3 to 12 months. So they are generally delayed diagnosis, 74% of the cases. And one of the 25 so 25 had family history, but only one had germline pathogenic variant of BRCA1. And majority of the breast cancer during pregnancy had dense breast parenchyma on mammogram with irregular masses without microcalcifications. So this is our TNBC is 41%, LABC 49%, and 97% grade 3. This is the principles of management. Essentially, it should be trimester dependent, and because in first trimester risk of malformation is 20%, we should avoid giving chemotherapy etc. in this period, and then judiciously we can start in second trimester onwards. Radiotherapy and targeted therapy reserved for post delivery. So this is the algorithm, and it depends upon gestational age, staging, biology, receptor status, genetic status, patient's general health, patient desire, and sign and symptoms. Precision management is the key, and must do in multidisciplinary setting, which involve neonatologist, obstetrician, counselor, and patient and partner, definitely along with other oncologists. So as I said, anti-HER2 therapy, radiotherapy, endocrine therapy after delivery, chemotherapy post second trimester, and surgery can be done in all trimesters. We will need to be careful in choosing what kind of surgery. So the TMC study treatment, it mirrors the standard management, what I just shown, and the survival in non-metastatic patients. So it is comparable to the published literature, and also with comparison to our young breast cancer data, also it is comparable. So stage-wise management and stage-wise outcomes can be comparable if you treat them appropriately. So this is by disease extent, and as we say, as the disease become from EBC to LABC to MBC, the survival goes down and down. So we have to be very careful, and early diagnosis is really emphasized upon. This is overall population survival. And this is the difference between antepartum and postpartum. This is during pregnancy or post-pregnancy. And again, it is matched with the world literature. So variables affecting OS and EFS were, again, disease extent, which is very important, and only independent predictor found for survival. This emphasizes the importance of increasing cancer awareness among young women to facilitate early diagnosis, also among the caregivers, because the first caregivers are generally obstetricians. They should be aware that not all breast masses are just due to pregnancy hormonal changes, and they need to be really aware that pregnancy can be, during pregnancy also they can have cancer, and we should not be neglecting that possibility. Toxicities, so they tolerated the therapies well, and there is some side effects like febrile neutropenia, mucositis, etc. But dose reductions in 7 patients, but there was no chemotherapy related death, and they were otherwise well managed. So the observations from TMH studies, like the very young women, median age of 31 years, majority were multiparous. This again highlight the socio-cultural trends in India. There is significant delay in the diagnosis, median 6 months, 77%. Higher postpartum cases in comparison to BCP. Maybe it's a reflection of delayed diagnosis as well. And otherwise also they found more common in postpartum stage. Aggressive biology, TNBC 43%, advanced stage, so they require aggressive treatments. And survival statistics were comparable to other PBC studies, and stage age-matched non-pregnant cohort in our EBC. So these are the take-homes from this very important study, that management must be performed in a specialized center by an expert MDT. Interrupting the pregnancy doesn't add any benefit to the mother, so it should only be considered in first trimester diagnosis. And parent decision definitely is very important, which may even be independent of the time of pregnancy. If the decision is to continue pregnancy, treat as you would treat in a non-pregnant case. And investigations are safe, like USG, MRI without contrast, mammography, if indispensable, X-ray, yes, preferably after delivery, bone scan, CT scan, PET, no, they should be avoided as far as possible. Surgery, yes. Chemotherapy, yes. Radiotherapy, not preferable. It should be delayed till the end, till the after delivery. Lactation, no. If on systemic treatment, otherwise, yes. Hormonal biological treatment, no. It can lead to syndromes like Goldenhar syndrome. This child is showing the same features. And surgery, similar approach as in non-pregnant, but careful anesthesiological evaluation and fetal monitoring. Breast conservation and construction is safe. Sentinel node biopsy is feasible, but without using blue dye. Avoid premature delivery to safeguard child long-term effects, and long-term cognitive function related with gestational age and not with chemotherapy cycles. Each pregnancy month, add 11.6 points to the intelligent coefficient scale. Very, very, very important finding must be noted. So our other efforts in triple negative segment, which is again a young breast cancer, and again it highlights that aggressive biology and predominated advanced stage, so we must diagnose them early, and this is very much unmet need in our country. We should be very, very careful in deciding. We must, and this is the conclusions towards the last. So young breast women are having specific challenges, including risk of overtreatment, which should be avoided, and psychological distress. However, growing resources are available and should be utilized. Oncofertility counseling is a must, irrespective of disease stage, and embryo and oocyte cryopreservation should be discussed as a standard option, and ovarian tissue cryopreservation as an alternative. Temporary OFS with GnRH analog during chemo should be considered to preserve ovarian function, but not as an alternative to cryopreservation techniques for fertility preservation. After adequate treatment and follow-up, pregnancy after breast cancer is safe, including among patients with hormone receptor positive disease and BRCA carriers. Pregnancy with breast cancer is managed as far as possible to standardized published protocols for young non-pregnant patients. However, management is trimester dependent. MBD care and adequate representation in trials is the key to help them navigate the disease and survivorship issues. And precision therapy of each young breast cancer is actually the way forward. We need to customize the product to our customers. And with this, I will thank each one of you for listening to my thoughts. And I'll be happy to take any questions, if they are. You can reach out to me anytime. And if I can help any which way to improve care for young breast cancer patients, I'll be really glad. Thank you very much.
Now I request my childhood friend Sapna Kale to take the session further. We are like school friends. Hello, everyone. It's a pleasure being here. I'm Sapna Kale. I work as a counselor with Snehanchal Palliative Care Center in Nagpur and helping out my friend Ruhi today. I would like to invite Dr. Captain Ritu Bayani, and I would like to introduce her to you all. She's a cancer warrior and founder of NGO Highways Infinite on borderless drives to empower people and impact lives before, through, and beyond cancer. She's brought together an innovative and rare blend of science, adventure sports, and cause to help communities at large. She set a fervent pace of breast, cervix, and oral cancer awareness and motivational campaigns across India, unparalleled in the history by any individual in India. She's a 3 times Limca Book of Record holder in 2007, 2008, and 2014. She was also invited as an external expert for WHO Guideline Development Group for referral of suspected breast and cervical cancer at primary health care in LMIC 2011-12. She has pioneered Project Highways 2006, India's first mother-daughter duo expedition, blending adventure drive with cancer awareness workshops across India. Highways Infinite, Attitude and Altitude, first international breast cancer survivors expedition on cancer advocacy and survivorship in India 2010. First cancer warrior to trek the TYAcan Glacier, world's highest and most treacherous battlefield and longest glacier outside the polar region. It was in September 2012. Then again, she is the first breast cancer survivor to compete in Raid the Himalayas, world's highest and India's toughest motorsport rally. She is also the first lady paratrooper from the Indian Army Dental Corps in 1984. She a mountaineer, skydiver, skier, solo, and rally driver.
first woman from Maheshwari, Marwadi and Gujarati community to join the Indian Armed Forces in 1981. Please give a big round of applause to Dr. Captain Yusubiani. Ma'am.
So let me at the onset just tell कि I'm an extremely good driver. My legs don't shake when I'm driving, but when I have to talk in front of people, जैसे हम सबको डर लगता है, तो मुझे भी लोगों के सामने बात करने में बहुत डर लग रहा है और पैर ऐसे यहाँ पे पोडियम के पीछे कांप भी रहे हैं. अगर बात करते समय अगर कुछ गड़बड़ हो गया तो भी हंस लेना और गड़बड़ नहीं भी हुआ तो भी हंस लेना, क्योंकि मेरा आज का टॉपिक है कैंसर और मैं, द फनी साइड, जो मजाक वाली बात होती है. And I will try and mix with Hindi and English because a lot of people told me to speak in Hindi also. So it is a hilariously innocent wild moment. कुछ लोग मुझे जानते हैं और वो ये भी जानते हैं कि जो मेरा जन्म हुआ है, so I was born to be wild. Wild समझते हैं सब लोग, है ना, थोड़ी सी बदमाशी, थोड़ी सी मस्ती, ऐसा ये सब करना चाहिए जिंदगी में, कैंसर हो या ना हो. I finish 22 साल, सितंबर 2000 मेरा एडवेंचर हुआ ब्रेस्ट कैंसर के साथ. आज सितंबर 2022 है and I'm still alive in front of you and I want to thank all of you for being with me. And at this junction, I would also like to thank Dr. Chitalkar and the entire TYAcan team 2022 for encouraging me to come. क्योंकि एक्चुअली कोविड सेकेंड वेव में जो हम लोगों को मदद कर रहे थे उसमें मेरे दिमाग में केमिकल लोचा हो गया था एंड मैं आई यूज्ड टू गेट डाउन इनटू अ लॉट ऑफ डिप्रेशन, नॉट कैंसर की वजह से बट जो लोगों के मैं हाल देख रही थी, तो ऐसा हेल्पलेसनेस आ रहा था. और मैंने सर को बोला भी था कि सर शायद मैं इस टाइम ठीक से लोगों को मोटिवेट नहीं कर पाऊंगी. फिर हमने डिसाइड किया कि क्या बात करें एंड देन वी डिसाइडेड कि मजाक वाली थोड़ी सी बात करेंगे. 22 साल के बाद आज भी मेरा यही मकसद है कि मैं भारत के कोने कोने में जाके कैंसर के बारे में जानकारी दूं. और ये जानकारी ऐसे बैनर लेके या मैसेजेस लेके नहीं है, ये प्रॉपर 2-3 घंटे के वर्कशॉप्स होते हैं ताकि लोगों के इसमें कैंसर लिटरेसी बढ़ा ले और लोग देरी से ना आए डॉक्टर के पास. अभी जब मैं पीछे मुड़ के देखती हूँ, ओके आई फॉरगॉट, इज एवरीवन कंफर्टेबल विद इंग्लिश, सॉरी हिंदी, ओके. सो अभी जब मैं पीछे मुड़ के देखती हूँ तो मैं वो दिन भूल गई हूँ जिसमें उल्टियाँ होती थी, दर्द होता था, डिस्टर्ब होता था. और सच्ची उस टाइम शायद लगता होगा, पर कुछ दिनों बाद, महीनों बाद ये सब गायब हो जाता है, यादें फेड हो जाती है. और कैंसर डेफिनेटली अनप्लेजेंट था, पर इट लेफ्ट इंटैक्ट स्पॉन्टेनियस क्रेजी एंड सिली मोमेंट्स फ्रॉम द होल. अभी जो मेरे को याद आते हैं वो मेरे मस्ती किए हुए दिन, खुद पे जोक मारे हुए दिन और डॉक्टर को भी दूसरी नजर से देखते हुए दिन, जिसको बोलते हैं माइक्रो क्रश. तो कीपिंग माई सेंस ऑफ वेटिनेस ड्यूरिंग टफ टाइम टिकल्स मी टू लाफ्टर. एक बाम की तरह, एक मरहम की तरह मेरे पे वो असर करता था एंड इट सॉर्ट ऑफ बैलेंसेस माई एग्जिस्टेंस. अभी जब आपको कैंसर हो ही गया है तो हम सब जानते हैं कि काफी लंबी ट्रीटमेंट चलती है, काफी दिनों, महीनों, कई बार साल चलते हैं. तो वो सारा आई मीन उतने दिन तो हम दुखी नहीं रह सकते ना, रह सकते, कितना वेस्ट ऑफ टाइम होगा ना. उतने दिन तो हम कंप्लेन भी नहीं कर सकते हैं, वो भी वेस्ट ऑफ टाइम है. तो मैंने डिसाइड किया कि ये बोरिंग मोनोटोनस जो वेस्ट ऑफ टाइम है उसको क्यों ना बीच बीच में कुछ जोक्स मारे. And let me churn out today some hilarious and innocently wild, जो मेरे लिए wild थे, जो मेरे लिए funny moments थे between cancer and me. And I hope कि इसके बाद शायद time मिला तो some of you all will share also. Mammography is a X-ray of breast. मैमोग्राफी मशीन, दो मैं डेंटल सर्जन हूँ, मैंने जिंदगी में कभी मैमोग्राफी मशीन देखा नहीं था, बाकी सारे एक्सरे मशीन्स देखे थे। तो आफ्टर जब वो लेडी टेक्नीशियन ने मेरे को प्रोसीजर एक्सप्लेन किया और उसने बोला कि ये ब्रेस्ट को हम ऐसे प्लेट्स में रखेंगे और वो प्लेट्स को कंप्रेस करेंगे अभी, एंड वो फिर बाद में भाग के वो सेफ गार्ड के पीछे खड़ी होगी जस्ट बिफोर द एक्सरे। हाउएवर इवन इन दैट एंशियस मोमेंट्स मेरे को तो फिक्र थी कि कहीं उसका कंट्रोल छूट गया वो प्लेट में से और वो पटाख से मेरा ब्रेस्ट के ऊपर वो कंप्रेस हो जाए तो क्या मेरे ब्रेस्ट कुछ ऐसे दिखेंगे, विल आई लैंड अप इन अ स्क्वॉश्ड अप ब्रेस्ट। तो वो भी दिमाग में साथ साथ चल रहा था 22 साल पहले। Most of my treatment was in army hospital. Post lumpectomy, I was advised mastectomy. और कितना भी मैंने खुद को प्रिपेयर किया था कि शायद ब्रेस्ट को निकालना पड़ेगा, तो भी एक छोटी सी किरण थी मेरे दिमाग में कि जो मेरे को बोल रही थी कि नहीं, TMH मुंबई जाके देखते कि उनके पास ऐसा कोई एडवांसेस है क्या जिससे मेरा ब्रेस्ट बच सके। एंड आई वॉज ओवरवेल्म टू सी कि TMH में जाने के बाद द ओशन ऑफ पेशेंट्स एंड केयर गिवर्स मिलिंग अराउंड और द जनरल एम्बियंस वाज वेरी ग्रे एंड ग्लूमी। When my turn came after much waiting, I saw the doctors in cabin. We got engrossed in clinical discussion. डॉक्टर के साथ क्लिनिकल जो भी मेडिकल की बातें हो रही थी वो हो रही थी और साथ साथ मेरे दिमाग में एक बोलते ना एक मस्ती वाली मिस्चीवियस जो कॉर्नर था, मैंने कुछ नोटिस किया और मैं आशा करती हूँ और मुझे पक्का पता है कि आप सबने भी उस टाइम नोटिस किया होगा, चाहे वो आपके मेल डॉक्टर्स रहे चाहे अदरवाइज आपके फीमेल डॉक्टर्स रहे, कि ये सारे डॉक्टर्स सडनली इतने हैंडसम, चार्मिंग और डेबोनायर क्यों दिखते हैं। इनमें से तो कुछ डॉक्टर्स को मैं पहले से जानती हूँ, एक अपने पास सामने बीच में बैठे हुए कर्नल चितालकर, उसके पहले तो मुझे कभी उनको चार्मिंग हैंडसम दिखा, मैंने उस नजर से देखा ही नहीं था। बट देन आई सडनली रियलाइज्ड, और सबसे पहले जो चार्मिंग हैंडसम दिखे वो है डॉक्टर बडवे। आई डोंट माइंड एडमिटिंग वाज डॉक्टर बडवे इन TMH। और सिर्फ मेरा ही क्रश नहीं है उनके ऊपर, सारे पेशेंट्स की उनके ऊपर क्रश है, माइक्रो क्रश, सॉरी। एंड और इवन माय डॉटर हु वाज 8 year old व्हेन आई वाज डायग्नोस्ड, उसको भी वो भी बोलती ओ डॉक्टर बडवे ओ ऐसे करती। So all the doctors be careful next time when you all are interacting with the patients. It reminded me of the movie and Mills and Boone Heroes. Is it because I was a damsel in distress? क्योंकि मूवीज में जाते हैं ना हीरो बचाने के लिए एक वो हीरोइन को, or is it because one keeps looking intently in their faces and eyes to find hope? मैं तो घुमक्कड़ हूँ, गाड़ियां बहुत चलाई हूँ, 2-3 लाख किलोमीटर अभी तक चलाई हूँ। पहाड़ मेरे फेवरेट जगह है और हर टर्निंग पे यू विल सी दिस, बी जेंटल ऑन माई कर्व्स। समझ में आ रहा है? तो ये मेरी सबको वार्निंग है, ऑल सर्जन्स को जो ब्रेस्ट कैंसर के केसेस हैंडल करते हैं, बी जेंटल ऑन आवर कर्व्स। और वो आर के बीच में एक यू भी है जो ब्लू में है, क्योंकि ब्रेस्ट कैंसर का साइन पिंक में रहता है, पर थोड़ा सा ब्लू ऐड करो क्योंकि मेल को भी ब्रेस्ट कैंसर होता है। सो द वार्निंग फॉर यू ऑल इज बी जेंटल ऑन आवर कर्व्स जब आप सर्जरी करते हो हमारे ऊपर। कीमोथेरेपी एंड मी, मेरी एक आदत है, मैं फौजी हूँ तो मेरे को रेकी एक रहता है कि जाके पहले पता करे कि क्या क्या होने वाला है मेरे साथ में। तो मैंने और ये नहीं कि आज डॉक्टर ने मुझे बोला और तुरंत कल मैं टेबल पे गई, ऐसे नहीं, आई हैड कुछ दिन थे। सो आई विजिटेड हॉस्पिटल वार्ड्स, पेशेंट्स के साथ इंटरेक्ट किए, वेरियस स्टेजेस जो उनकी ट्रीटमेंट चल रही थी। एक लेडी ने मेरे को बड़े प्यार से अपना खुद का वो भी दिखाया, जख्म भी दिखाया कि मैस्टिक ब्रेस्ट निकालने के बाद कैसा होगा, सारे फर्स्ट हैंड एक्सपीरियंसेस लिए एंड मेंटली एंड लॉजिकली मैंने अपने आप को प्रिपेयर किया कि चलो अब ये लड़ाई क्षेत्र में उतरना है। एंड सपोर्टिव फैमिली थी, मेरे बहुत इनक्रेडिबल डॉक्टर्स थे एंड एज अ डॉक्टर मेरे को खुद को मेडिकल जानकारी थी, जो नई जानकारी थी वो मैंने ले ली खींचतान से, एंड आई एंटर्ड द एरिना टू टैकल दीज इन्वेडिंग कैंसर सेल्स। कितना भी मैं प्रिपेयर होके गई, कीमोथेरेपी डिड कम एज अ नॉकआउट पंच, धड़ाक से। क्राउनिंग ग्लोरी, क्राउनिंग ग्लोरी का मतलब है ये अपने सुंदर सुंदर बाल। We all are aware कि chemotherapy induced hair loss evokes a lot of stress and anxiety in patients and especially women patients. आई नेवर कंप्लीटली अंडरस्टूड तब भी। मुझे ऐसा लगा कि जब यहाँ पे हम जिंदगी से लड़ने की कोशिश कर रहे हैं तब ये छोटे बाल गिरना, ब्रेस्ट उड़ना, आई मीन ये तो बहुत ही छोटी सी बात है। जान है तो जहान है, यहाँ जान बचाने की पड़ी है तो बाल झड़ना तो बहुत ही छोटी सी बात है। रिमेम्बर, वो पीरियड था जब कैंसर छुपाया जाता था। आज एटलीस्ट कुछ लोग कैंसर के बारे में बोलते हैं। अभी तो मैं डॉक्टर हूं, मैं भूल गई, और मेरा हक बनता है कि मैं पेशेंट की तरह ही बिहेव करूं, बराबर ना। आई कांट बी अ डॉक्टर ऑलवेज। तो मेरे यहाँ जो मेरे को पेशेंट्स थे वो टकलू हो रहे थे, और यहाँ पे 2 कीमो के बाद भी मेरे बाल झड़ नहीं रहे थे। एंड मैं सोच रही थी कि ये पोटेंसी एंड प्योरिटी ऑफ द ड्रग एंड ड्रग कंपनी, आई स्टार्टेड सॉर्ट ऑफ वंडरिंग वेदर दे आर गिवन टू मी राइटली और नॉट। बैक टू डॉक्टर्स ऑफिस। डॉक्टर, तुम्हारे ये दवाइयाँ कुछ ठीक नहीं लग रहे हैं। अगर वो मेरे बाल नहीं झड़ा सकते तो वो मेरे कैंसर सेल्स को कैसे मारेंगे? एंड दिस आई रियली डिड इट। आई क्वेश्चन माय डॉक्टर, एंड डॉक्टर ने बड़ा पेशेंटली जो भी एक्सप्लेन करना है किया, मैंने भी सुना, पर डीप इन माय माइंड मुझे वो थोड़ा सा ये रहा था कि कुछ तो भी गड़बड़ है ये दवाई का। वैसे दवाई का गड़बड़ नहीं था, पर ये मेरे दिमाग में था, और वो इसलिए था क्योंकि कई लोगों की हम कहानियां सुनते। I was influenced by hundreds of cancer stories and advices जो which was awake, और उसमें मैं भूल गई कि मैं एक मेडिकल डॉक्टर की तरह नहीं सोच रही हूँ। जब बाल गिरे थोड़े थोड़े आईसीयू के बेड के पिलो पे, मैंने बोला हुर्रे लाउडली, एक टार्जन जैसे येल करता है ना वैसे। सिस्टर्स दौड़ते हुए आई, क्या हुआ? मैंने कहा बाल गिर रहे हैं। तो दे सेड मैम, women feel sad when they see the hair falling, and here you are enjoying it. During the initial hair fall, मेरा जो head था, it was looking like a plucked chicken with its patchy appearances. आज के दिनों में वो प्लक चिकन नहीं बोलते, पंक स्टाइल बोलते शायद। तो मैंने ये घर पे बताया नहीं था कि मैं जाके बाल उड़ा, बचे हुए बाल उड़ा के आ रही हूँ। और जब मैं अपने आप को एडमायर कर रही थी पार्लर के मिरर में, अपना टकलू, नया टकलू रिफ्लेक्शन, तो मुझे याद आए 2 फेमस विलन्स। शायद आई डोंट नो द न्यूअर जनरेशन नोज देम और नॉट, बट आई एम श्योर ऑल ऑफ यू नो मिस्टर शाकाल फ्रॉम शान, जो मगरमच्छ को अपने दुश्मनों को मगरमच्छ के आगे देता था, एंड मिस्टर अर्नेस्ट ब्लोफील्ड फ्रॉम जेम्स बॉन्ड मूवी, जो मगरमच्छ को नहीं पर पिराना फिश को अपने दुश्मनों को उनको खिलाता था वो। और एक ये मैं थी। After all, you only live twice. That's the name of the James Bond movie. And शाकाल का पिक्चर का नाम था शान। तो हम जी रहे हैं तो शान से जी रहे हैं। तो मैं आशा करती हूँ कि वहां पे एक छोटी सी लड़की बैठी है, वो लास्ट में आके अपनी टोपी उतार के सबको अपना टकलू शान से दिखाएगी। जब मैं घर पहुंची तो नेचुरली उनको पता था कि बाल जाएंगे, बट फिर भी वो टेंस्ड हो गए थे कि सडनली मैं दरवाजे पे एक टकलू चेहरा खड़ा है। एंड मैंने उनके टेंस फेसेस देखे, मैंने उनकी आंखों में दर्द देखा, तो मैंने अपने बाल पे ऐसे हाथ, आई मीन टकलू पे ऐसा हाथ घुमाया और मैंने कहा मुगाम, वो खुश हुई। कितने लोगों ने मूवी देखा? आई डोंट नो, फाइंड आउट। एंड दे ऑल बर्स्टेड लाफिंग एंड द स्ट्रेस मेल्टेड। कि कभी कभी खुद पे मजाक करने से भी थोड़ा बहुत स्ट्रेस कम होता है। और देर आफ्टर जो भी मैं पेशेंट्स मिलती थी, मैं उनको बोलती थी फोटोज लेना मत भूलना, चाहे कुछ भी हो जाए, हर एक स्टेज के फोटोज लेना। हो सकता है बाद में कभी वो देखते देखते हंसी आ जाए। आई नेवर कवर्ड माई हेड विथ अ स्कार्फ, विग और कैप। आफ्टर ऑल, कितने ऐसे लेडीज है उस टाइम में, उस जमाने में, जो अपना टकलूनेस दिखा के शान से सेंटर ऑफ अट्रैक्शन बन सकते थे। पर वो सेंटर ऑफ अट्रैक्शन बनने से, और मैं अपने बीमारी के बारे में बात करती थी, तो काफी लोग चेकअप के लिए गए। काफी मेरे जान पहचान के, अरे इसको कैंसर हो सकता है, तो फिर एटलीस्ट उस बहाने वो चेकअप के लिए गए। पर जो मेरा पहला डेंटल पेशेंट था, जो लेक्चरर थी, शी आस्क्ड मी इफ आई हैड गॉन टू तिरुपति, क्योंकि मैं तो विग पहना नहीं था, बैठी थी। एंड आई हैप्पीली टोल्ड हर नो, आई एम अंडरगोइंग ट्रीटमेंट फॉर कैंसर। डेंटल चेयर सबने देखा है? इज इट इजी टू जंप आउट ऑफ इट? नो, बट शी जंप्ड आउट। वो भागी और चली गई। क्यों? बिकॉज शी थॉट कि मेरा कैंसर इन्फेक्शियस हो गया. This is for the doctors. 14th February 2001, Valentine's Day gift. One medicine which made Ritu the Bevdi. Bevdi समझते हो? Everybody knows Bevda, Bevdi. Okay. So ये मेरा सेकेंड लास्ट कीमो था एंड एज यूजुअल सब कुछ रूटीन चल रहा था. एंटी वॉमिटिंग ड्रग्स दिए, सेटल डाउन हो गई. नर्सेज वगैरह डॉक्टर्स को देख रही थी जो अपने अपने रियल आईसीयू पेशेंट्स की तरफ घूम रहे थे ऐसे. एंड सडनली मेरे को अपना एक टांग ऐसे हिलते हुए देखा. फिर पूरी बॉडी ऐसे अपने आप ही हिल रही थी. एंड एज अ डॉक्टर एंड फिर मैंने ऐसे देखा ऊपर क्योंकि ऐसे लेटे थे, तो आई सॉ द वॉल्स गोइंग लाइक दिस. सब कुछ हिल रहा था तो मेरे को समझ में नहीं आ रहा था. बट एज अ डॉक्टर जो मेरे को लगा था कि कुछ तो भी ड्रग रिएक्शन हो रही है. और ड्रग रिएक्शन तो मुझे लगा, फिर एनाफिलेक्टिक शॉक भी कहने, मेरी सांस भी से रैशेस वगैरह आने चाहिए, वो कुछ नहीं आ रहा था. ये कुछ अलग ही था. आई ट्राइड कॉलिंग द डॉक्टर्स, नर्सेज, मुझे मेरी आवाज नहीं सुनाई दे रही थी. एंड फिर मैंने देखा कोई मेरे को उठा रहा है, चप्पल में अपना पैर डाल रहा है, तो मैं अपना पैर चप्पल में घुसा रही थी. जस्ट लाइक केशव मुखर्जी. कितने लोगों ने केशव मुखर्जी के मूवीज देखे हुए हैं? ही इज अ ओल्ड टाइम कॉमेडियन, हिंदी मूवी कॉमेडियन, जो हमेशा ड्रंकेड दिखाता था और वो ऐसे ही ऐसे करता था वो. तो मेरा भी हालत कुछ ऐसे ही था. एंड that actually became the classic example of extra pyramidal reaction, and which I told the doctors later. डॉक्टर सेड आपने हमको बहुत टेंशन में डाल दिया. मैंने कहा नहीं, मुझे तो बहुत मजा आया, क्योंकि मैं एक डॉक्टर की जगह 3 डॉक्टर देख रहे थे मेरे को उस हालत में. एंड आई विश दैट वीडियोग्राफ दैट सो दैट द अंडर ग्रेजुएट स्टूडेंट्स के लिए ये काम आता था. आई हैव आर्टिफिशियल प्रोस्थेसिस, ब्रेस्ट एक नकली प्रोस्थेसिस में लगाती हूँ. एक बार ट्रीटमेंट होने के बाद, सब ठीक ठाक होने के बाद, मैंने डिसाइड किया कि मेरे को स्विमिंग तो सीखना है, बिकॉज आई वॉज वेरी स्केर्ड ऑफ वाटर. चलो स्विमिंग चलने जाते. और मैं भूल गई वो प्रोस्थेसिस मेरा स्विम कॉस्ट्यूम के अंदर रहा. ये दिस इज इन अर्ली 2000. देयर वाजंट मच सपोर्ट अवेलेबल इन इंडिया फॉर वुमेन हु इज अंडरगोइंग मास्टेक्टोमी इन टर्म्स ऑफ लॉन्जरे और स्विम वेयर. इट डिड नॉट बॉदर मी. शैलो पूल में मैं डुबकी मारा एंड मेरा पूरा फोकस था अपने ब्रीदिंग पे, क्योंकि आई डिडंट वांट द वाटर टू गो इनसाइड. And this was a army club ka swimming pool. Amidst what all that's a lot of splashing going on, a gentleman officer on his swimming laps pointed out to something floating alongside me. Lungs half filled with water, I saw that something was my breast prosthesis that had escaped. वो breast मेरा prosthesis बाहर निकल के मेरे साथ swim कर रहा था, और ये कोई आदमी नहीं देखा था. Imagine this thing. So between the two of us, my prosthesis was definitely a better swimmer. अभी बात हो रही थी ड्यूरिंग द कॉन्वर्सेशन दैट फियर होता है, सबको डर लगता है, मुझे भी डर लगता है. पर वो डर को ओवरकम करना जरूरी है. पर मेरे इसमें कुछ कुछ ऐसे डर है जो मैं उसको कभी कंट्रोल नहीं कर सकती हूँ, मेरे आउट ऑफ कंट्रोल है. फियर इज एसेंशियल एंड नेचुरल. When faced with crises like cancer, fear is an honest emotion, but one needs to overcome the fear to confront and so that you can focus on the treatment. Everyone thinks I'm a brave person. तो वो बचपन से, अरे रितु ये तो बहुत ब्रेव है, उसको कुछ नहीं होगा. पर वो नहीं जानते थे कि मुझे सुई की बहुत डर है. लाइक इन स्पाइट ऑफ बीइंग अ डेंटिस्ट, आई हैव अ लॉट ऑफ डर फॉर नीडल पिक्स लाइक दैट. एंड ये सुई की फोबिया का मेरे को ये भी पता है कि मेनी ऑफ दिस फियर्स आर नॉट इनेट इन अस, बट दैट आर व्हाट वी हैव एक्वायर्ड, जस्ट लाइक द फियर ऑफ कैंसर व्हिच हैज बीन पास्ड थ्रू द जनरेशंस. स्टेपलर्स में एक दो बस अभी एक दो अपने ये दिखाती हूँ. स्टेपलर्स, आई मीन स्टेपलर्स आर द स्टिचेस जो पूरे लगे थे ऐसे. एंड आई वाज टोल्ड कि आप ऑल्टरनेट स्टेपलर्स निकालने, यू गो टू सम क्लोज बाय डॉक्टर, जिनके यहाँ मैं गई. दैट गाय वाज आल्सो हैंडसम गाय. ओके, सो मैंने उनको एज यूजुअल पूछा कि मेरे को तकलीफ तो नहीं होगी. तो ही सेड नहीं. दो मुझे पता था कि तकलीफ नहीं होगी, पर मैंने बोला ना कि कभी कभी अपना डर इतना अपने पे बैठा रहता है कि कुछ कितना भी बोले उसमें कोई सोल्यूशन नहीं निकलता. तो आफ्टर रीअश्योरिंग मी, उसने अपना पहला स्टेपल निकाला मेरा, और जैसे ही वो स्टेपल निकाला उस हॉल में जोर से आवाज आई या करके. मैं भी देख रही हूँ, वो भी देख रहे, जो मेरे साथ थे वो सारे देख रहे थे. एंड मेरे को भी समझ में नहीं आया कि हॉरर मूवी की तरह ये आवाज कहाँ से आई करके. तो डॉक्टर भी एकदम स्टिफ हो गया, बोला व्हाट हैपेंड. मैंने कहा कुछ नहीं. ही सेड फिर तुम स्क्रीम क्यों किया. मैंने कहा मुझे नहीं पता कि मैंने स्क्रीम किया, शायद अपने आप आ गया होगा क्योंकि मुझे डर लगा था. और शायद उसके पेशेंट्स भी भाग गए होंगे जो बाहर थे वो. सो दीज आर द बैड एग्जाम्पल्स कि जो मैंने डॉक्टर को भी तकलीफ में ट्रबल में डाला। साहस का अर्थ यह नहीं है कि भय का अभाव है, बल्कि यह निर्णय है कि भय से अधिक महत्वपूर्ण कुछ और है। Courage is not the absence of fear, but rather the judgment that something else is more important than fear. So friends, my doctor friends, my team, the entire TYAcan team, and most importantly, जो ये vibrant survivors and patients आज है यहाँ पे, find opportunities to laugh away the challenges. Who knows which crises and difficulties will change your destiny? मुश्किलों से हंस के मिलो, क्या पता कौन सी मुश्किल आपकी मुकद्दर बदल देगी। अभी भी बहुत सारे माइल्स मेरे को चलाने हैं। थैंक यू सो मच।
Now we will be having the panel discussion. The topic for the panel discussion is broken crayons, still color. And for that, I would like to invite Dr. Ritu Biani as the moderator. And I'm calling out the names of the panelists whom I request would please join me on the stage. Ms. Ruhi Ahmed, Ms. Pooja, Ms. Shefali Seriwal, Ms. Rashmi Deshpande, Ms. Bhavna Srivastav, Ms. Barkha. And Dr. Rakhi.
So welcome all fellow travelers and जो ये आपका टॉपिक है ब्रोकन क्रायॉन स्टिल कलर, मेरे को इसका टाइटल बहुत अच्छा लगा। जैसे टूटे हुए क्रायॉन्स भी आखिरी दम तक कागज पे रंग भरते रहते हैं, जैसे टूटे हुए क्रायॉन्स भी आखिरी दम तक कागज पे रंग भर सकते हैं, वैसे ही कैंसर योद्धा आखिरी दम तक अपनी जिंदगी रंगीन बना सकता है। I didn't realize I'm becoming a shire also now. Okay, and I will have give you all some questions, just 1 or 2 words या 1 or 2 sentence में। तो पहला ये पूछ रहे कि कैंसर का डायग्नोसिस होने के बाद, पहले रूही को बताएंगे, आप कितने घंटे, दिन, महीने या साल दुखी रहे?
ओके मुझे कैंसर हुए बहुत दिन नहीं हुए हैं। 2019 दिसंबर में आई वाज डायग्नोस्ड विद कैंसर एंड बिलीव मी, जब मुझे पहली बार पता चला कि मुझे कैंसर है तो द फर्स्ट थॉट दैट केम टू माय माइंड इज माय करियर। इट्स नॉट दैट मुझे क्या अब क्या होगा, बस ये पता था कि बहुत लंबा ट्रीटमेंट है, पर मुझे ऐसा लगा अब मेरे करियर का क्या होगा जिसको मैंने शेप दिया है। आई एम अ प्री प्राइमरी टीचर and I have done few courses for also for that. So वो पहला fear आया था कि ओ मेरी job चली जाएगी और मैं इतना लंबा कौन school मुझे support करेगा, but thankfully मेरा school I work for श्री सत्य साई विद्या विहार, so वहाँ पे जो principal थी and the management उन्होंने मुझे बहुत सपोर्ट किया. इनफैक्ट मुझे सत्य साई ज्वाइन किए से 5 महीना हुआ था और उन्होंने मुझे 6 महीने की लीव विद पे दी थी. दैट्स अ बिग थिंग. नहीं तो कोई भी होता वो कहता कि ठीक है मैम, यस आप चले जाओ ट्रीटमेंट के लिए, बाद में जब वैकेंसी होगी विल कॉल यू बैक. इस तरह के एक्सक्यूजेस देते हैं बिकॉज आई हैव बीन इनटू मैनेज एडमिनिस्ट्रेशन आल्सो एंड आई इनटू दिस व्हाट यू कॉल hiring the teachers, so I know what kind of things people say. So but then they supported me. And second fear was my son was in 12th class, so that was also fear that I'll go for a treatment and what will happen to him, because he couldn't leave me alone. Sorry, मैंने लंबा time ले लिया, आपने 2 line बोला था. So but he couldn't leave me alone, so he also came with me to Mumbai. My surgery was done in Mumbai by Dr. Praful Desai in Breach Candy Hospital.
Okay, is it Rashmi? Yeah.
Yes.
Rashmi, 2 लफ्जों में
हाँ.
कितने घंटे, दिन या महीने या
मैं
साल?
कितनी बार बताऊं, मतलब 10 साल से मेरे पास कैंसर है, 4 बार हो चुका है. और मुझे हंसी आती है अभी तो. अगर यार चलना है क्या, कीमो कब से शुरू करनी है बताओ. मतलब इससे अभी मुझे कोई पहले पे मुझे डर नहीं लगा. एक ही दिन मुझे लगा कि कैसे कैसे, फिर मैं तो चलो करना है ना. 120 कीमोथेरेपी ली है, 10 ऑपरेशन हो गए हैं, 2 बार रेडियोथेरेपी, पूरा ब्रेन में मेटास्टेसिस हो गया है. मुझे किसी से डर नहीं लगता, पहले भी नहीं लगता था, अभी भी नहीं लगता. कब करनी है कीमोथेरेपी नेक्स्ट बता दो. अभी रिसेंटली हुई है, अभी 21 को फिर से है. फिर
Dr. Rakhi?
All inspiring ladies over here. I'm Dr. Rakhi and working in physiotherapy department as a professor. It was in year 2012 I was diagnosed with breast cancer, and again I had a relapse in 2017 for ovary cancer. So I'm also a 2-time cancer survivor. But yes, initially जब जो मैडम ने क्वेश्चन पूछा, yes, it was difficult to accept it because it is a thing that is actually very difficult to accept for anyone कि आपको ये चीज हो गई है. Especially I was more worried because when I was diagnosed with the cancer, my daughter was only 4 years. So at that time the biggest fear that I had is कि अब इसका क्या होगा. I mean, because my stage was 3rd stage when I was diagnosed with cancer. So मुझे ये था कि अब इसका क्या होगा, वो मेरा biggest fear था. But then because I didn't take much time to come out of it, क्योंकि I was already into spirituality and meditation, and throughout my cancer journey I will tell you that has helped me a lot.
Thank you. Okay, मुझे ऐसा लगता है कि काफी लोगों ने मेरे दूसरे तीसरे सवाल का भी जवाब दे ही दिया है. So I'll go on the one of the major question. पोस्ट कैंसर, अभी या तो आपकी जर्नी चल रही है या तो आपका ट्रीटमेंट पूरा हो गया है और अभी रहा है आगे चलने के लिए. तो ये जो ब्रोकन क्रायॉन जो हमने टाइटल दिए हुए, जो टूटे फूटे रंगीन क्रायॉन्स या कलर पेंसिल से आप अपने जिंदगी का कलर जिंदगी या आपके सपने कैसे कलर करना चाहते हो, संक्षिप्त में बताइए आज के बाद से, बहुत संक्षिप्त. आई थिंक आई स्टार्ट विद प्रायोरिटी, तो अभी रश्मि को जाएगी.
मैं तो ऐसे समझती नहीं कि कैंसर से मुझे कुछ तकलीफ हुई है, बेटर ही हुआ है. मैं पहले एकदम कर्ली बाल नहीं थे, अभी भी आ रहे हैं, कर्ली बाल है. और मेरे साथ बहुत सारे लोग जुड़ गए हैं, जो सपोर्ट मुझे मिलता है, जो दुआएं मुझे मिलती है. तो मैं तो लकी मानती हूँ कि ये जो कैंसर आया है ये मेरे लिए बहुत ही अच्छा है. और स्पेशली मैं गाना बहुत अच्छा गा रही हूँ कीमोथेरेपी के बाद, तो वो भी बहुत अच्छा है.
इसका मतलब कीमोथेरेपी के पहले गाने नहीं गाते थे?
मैम मैं गाती थी पर मेरा आवाज इतना अच्छा नहीं था.
Oh, so all the onco physicians
और टॉन्सिलाइटिस बार होता था, तो टॉन्सिलाइटिस भगा दिया कीमो ने.
So all the onco physicians, that's a plus point for you all. And Rashmi, Dr. Rakhi.
Again, I will say that जितनी स्ट्रांग मैं अभी हूँ कैंसर के बाद, शायद मैं पहले कभी नहीं थी. और मुझे ये मानना है कि मेरे लिए एक ये लाइफ चेंजर था, क्योंकि जो चीज मैंने कैंसर के पहले नहीं करी वो सब कुछ मैंने कैंसर के बाद किया है.
It may be any achievements, any awards which I'd never got before the cancer. I got everything out after that. And मुझे ये लगता है कि भगवान ने अगर हमको चुना है, उसका एक मकसद हर समय होता है. There's a reason behind it, that why you have been chosen for this particular cause. And I am happy that I am able to do it, because इसके बाद जो हमने cancer awareness हमने फैलाना चालू किया colleges में, schools में, and now also we have Nivaran group in which we are doing awareness and counseling for so many thousands of patients. अभी हम लोगों ने करीब 3,000 patient को हमने पिछले 2 महीने में cover कर लिया है. Then of course गाना जैसे मैडम कहती है, तो आई एम ऑल्सो सिंगर. मैं पहले भी गाती थी, मैं अब भी गाती हूँ. सो 2 लाइन जरूर गाऊंगी.
रुको 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 रुको, पहले रूही को पूछते हैं, क्योंकि उसके बाद मेरे को एक आपको सरप्राइज देना है, फिर आप तब गाना गाइए दोनों. रूही, जिंदगी को कैसे
जब मुझे कैंसर नहीं था, मैं बहुत वर्कहॉलिक टाइप की थी. मैं बहुत हर वक्त काम करती थी, या स्कूल में या घर में, या कुछ ना कुछ ढूंढ के कुछ करती रहती थी. बट देन आफ्टर कैंसर आई स्टार्टेड डिस्कवरिंग माई सेल्फ, knowing thyself. I started working on that, and now I spend a lot of time with my friends, leisure time. I I like doing embroidery, so I do that. I like cooking, so I started spending time in that. So that's how I'm going to bring difference in my life, as well as thanks to Dr. Chitalkar, who has, like, he's been trying from last 2 years. He used to tell me, come dekho, samjho cheezon ko. But this time मैंने थोड़ी हिम्मत जुटाई और आई, and I'm really liking it, sir. Thank you very much. So I would like to go further in this also.
Okay, the surprise this thing is today is Ruhi's birthday. और भी किसी का बर्थडे है, बिकॉज ये अभी छोटा सा 2-3 लाइन में गाएंगे तो ये सबके लिए होगा जिसके बर्थडे है. और भी किसी का बर्थडे है? Okay, Ruhi, many happy returns of the day from all of us.
Happy birthday, and may you have a very, very long life.
And Rashmi or Rakhi can probably.
I like to sing just 2-3 lines. That is also a motivating type of song for survivors also. And many times I used to sing myself also. जब मुझे कभी ऐसा लगता था कि नहीं, अभी तो बैटरी चार्ज करनी है, तो मैं ये गाना कर लेती हूँ. ये मत कहो खुदा से मेरी मुश्किलें बड़ी हैं, ये मुश्किलों से कह दो मेरा खुदा बड़ा है. आती है आंधियां तो कर उनका खैर मकदम, तूफान से लड़ने ही तो खुदा ने तुझे जड़ा है. Thank you. Thank you, Chitalkar sir, for inviting us.
Rashmi, दो लाइनें गान, only 2.
बार बार हाँ बोलो यार हाँ, अपनी जीत हो उनकी हार हाँ. Thank you.
Thank you so much. Thank you, sir. Thank you, everybody. Any questions for them? Ma'am?
Yeah. See, I would like to say the other side of the table. हमारी आंखों में आंसू होते हैं जब हमें ये वाली चीज आप लोगों को रिवील करनी है. And after listening to you, Ritu, and every one of you, I'm so happy. I'm glad that no, the things can be different at my heart also. I can also cheer up the people. So thank you very much, Chitalkar, for calling me. Yeah, thank you.
Thank you so much.
Before I announce about the lunch break, I would also like to speak a little bit about Dr. Rachna Date. She's the founder, director of Quest Education, and is contributing along with her happiness volunteers every year for this conference. Quest Education conducts skill development training programs and workshops pan-India. Dr. Date and her team work to spread happiness and bring smile to everyone and everywhere. And while we break for lunch, I would request everybody to please visit the happiness corner that they have developed in the lobby. Thank you.
I would like to call my volunteers.
Yeah, sure. Sure.
Ladies and gentlemen, this is a group of normal students from Indore colleges, and Dr. Sapna Date has been kind to, Dr. Rachna Date has been kind to get them over here, especially as an educational opportunity for them. And I would like them to express themselves what they've been doing. I mean, what they've actually learned in this morning by being with us. Because the idea is to spread the message through normal society. You know, everybody thinks we are very morbid people. We keep on talking about cancer, but here a group of normal people who will tell you what they understood, what they felt about our focus on young people's cancer. Dr. Rachna.
It will be better if we ask them.
Anyone? Hello everyone, I'm Vartika. So when we came here, we didn't really know what to expect. But as you may have been to our corridor, Dil To Bacha Hai Ji. So when we were there and we were talking to the patients and we were helping them with the games and all, so we realized that everyone just wants to have fun and live normally. So maybe we need to normalize cancer a little more and just live a little happily and just be free about it. So rather than it being such a taboo in the society and being so concerned, we should try to normalize it a little more. Yeah.
Okay. First of all, thank you, ma'am, for giving us the opportunity to come here today. We were able to interact with so many people, and not only to them, but it was also a moment of happiness for us also, because everyone is under stress for some or the other reason, but we got to play today and have fun with others. So it was a great opportunity. Thank you all for participating.
Thank you. Can any one of you tell me what will you do if you next week somebody in your either family or friends or college or class is diagnosed with cancer? What will you do? What best you do?
We'll make them feel happy, like we'll play with them as we do it today. basically when someone is diagnosed with cancer or something, हम उन्हें बहुत अलग feel कराते हैं कि they are different from the society. तो मैं चाहूंगी कि वो बिल्कुल हमारी तरह फील करें. जैसे आज एक बच्ची थी, उसने जब मेरे साथ डांस किया, उसने जब मेरे साथ फोटो खिंचवाई, मुझे बहुत अच्छा लगा क्योंकि वो भी हमारी तरह ही रहना चाहती है. हमें उन्हें अलग नहीं रखना चाहिए. If someone is like shaving their head, so I would love to accompany them and I would shave my head too. So that is what. Anyone else?
Hello everyone, myself Nandini Gunwane. I want to share my experience of coming here. I enjoyed coming here and learned, interacted with many people. It was a great experience and get to know about the cancer survivors. And I enjoyed with the cancer survivors, and they were so nice with us, and we had a good time with interacting with doctors and patients. And thank you, ma'am, for taking us here.
One word answer. How to remain friends with a cancer patient?
I guess normally as we are with normal people.
We have to make connect to them.
Very good afternoon, all of you. My name is Tanu Rajore. मैं आप सभी को ये कहना चाहती हूँ कि आज जो भी वॉरियर्स हमसे मिले और हम लोगों से उनका इंटरेक्शन हुआ, वो बहुत ही ज्यादा हम लोगों को अच्छे लगे. हमसे उनको बहुत सारी चीजें देखने को मिली, समझने को मिली, उनको सीखने को मिली. उन्होंने हमारे साथ में बहुत सारे गेम्स खेले, डांस किया. इससे हम लोगों को भी बहुत ज्यादा खुशी हुई. मैं आज तक कभी भी ऐसे इवेंट में नहीं गई थी. थैंक यू सो मच मैम कि आप मुझे इतने अच्छे इवेंट में लेकर आए. जो आज आपने मुझे इतनी अच्छी अपॉर्चुनिटी दी कि आज मैं स्टेज पे खड़े होकर आज सभी लोगों के सामने बोल पा रही हूँ. मैंने आज तक लाइफ में कभी नहीं बोला. और मैं थैंक यू.
We can be their friends. Positivity.
Trust between each other.
Smile, Muskan.
Spread happiness.
We can support them throughout their journey. To make them happy or comfort feel करवाए. So thank you so much for having us here.
You actually brought out a new side of our work.
Sir?
I just want to address this young minds. Disease does not take away the person. It still remains very much.
Sir, just one thing. Sir, actually बहुत अच्छा लगा. It's warriors, patients, doctors, हम सब मिलते रहते हैं. But ये जो है जिनसे अलग से interact करना, इन्होंने अपने अपने points तो बताए कि motivation, support, comfort करना बहुत जरूरी होता है. जैसे रितु मैम बता रहे थे कि उनका experience, अभी भी लोग बताने के लिए डरते हैं या थोड़ी हिचकिचाहट होती है. फैमिली या फ्रेंड्स के अलावा आजू बाजू में मतलब फ्रेंड्स को भी नहीं बताया जाता या फैमिली को भी नहीं पता होता है. तो जब 1 से 2 को 2 को 10 से जाता है, जैसे आपकी अभी ये 10-12 लोगों की टीम है, तो आपसे भी वो काफी लोगों तक जा सकता है. चाहे वो आपका कॉलेज हो, फैमिली हो, फ्रेंड्स हो, आपके एरिया में कोई है, जरूरी नहीं कि वो अपना नेबर ही हो, कोई अननोन भी हो सकता है. यस, उसे कंफर्ट करना, बिकॉज नॉट ओनली चाइल्डहुड कैंसर इज क्यूरेबल. एनी कैंसर जो डिटेक्ट होता है अर्ली स्टेज में वो क्योर हो सकता है, और उसके लिए सोसाइटी से यही एक्सेप्टेंस रहता है. सो एक्सेप्ट मतलब यही एक्सेप्ट करते हैं. थैंक यू.
सॉरी, मैं हमेशा बोलता हूं और मैंने एक पोस्टर भी बना के रखा है, एंड आई से कैंसर इज मोर मेलाइंड देन इट इज मैलिग्नेंट. I tell everybody, it is more maligned than it is malignant. Why we talk so much about this? Negativity should not be crept into that. Thank you very much.
So 30 साल पहले जब when I was at Tata Hospital training with Colonel Chitalkar and I met Dr. Advani, he was my guru and teacher. He used to say कि हेमंत जब तुम 10-15 साल ऑन्कोलॉजी प्रैक्टिस कर लोगे तो जैसे आज लोग कहते हैं कि मेरे को हार्ट का ऑपरेशन हुआ और 3 ग्राफ्ट करते हैं, मुझको 5 ग्राफ्ट लगे। 10-15 साल में लोग खड़े होकर ये बोलेंगे कि आई एम कैंसर सर्वाइवर एंड दैट्स बिगिनिंग टू हैपन, इट्स बिगिनिंग टू हैपन।
सर वन पॉइंट, जैसे ये टीम है वैसे अभी जो मैंने जो दिखाए थे सब कार्टून्स, तो ये मेरे को सुबह 9:30 बजे तक मिले। अनदर नॉट अ कैंसर सर्वाइवर बट अनदर पर्सन लाइक दिस वाइब्रेंट जनरेशन, जिन्होंने फटाफट कार्टून्स बना के मेरे को सुबह सुबह भेजे। एंड शी इज सौम्या अय्यर। तो जो प्रीति बोल रही थी कि सपोर्ट ये सिर्फ हमारे ही नहीं रहते, कि हम ये नहीं चाहते कि हमें सपोर्ट करो, बट इट इज जस्ट दैट यू हैव टू बी जस्ट नॉर्मल। एंड हाँ, कुछ चीजें अगर नहीं कर पाए तो जैसे आप लोग फ्रेंड्स में एक्सचेंज करते हो, शेयर करते हो, वैसे हम भी चाहते हैं कि शेयरिंग हो जाए, कि हमारी तरफ से भी कुछ शेयरिंग है तो हम कर सकते हैं।
Absolutely. Thank you so much. Yeah. Thank you. So, this.
Yeah. Sir, you also.
ये सामने देखिए, स्माइल बहुत अच्छा। स्माइल सर, आप देखिए बहुत अच्छा। सुपर।
So please, yeah, and we will get back here in 25 minutes, if you please. Yeah. Yeah.
Now, busy in the sense, employment, जैसे अभी